Well, good morning, everyone. I'm Larry Boris, the Executive Director of the National Association of Worksite Health Centers. I want to welcome you to our program today, Creating Hospital Managed Worksite Centers for their own employees and area employers. This is a topic that continually comes to the fore at our programs and in our evaluations. We have an increasing number of hospital, health system, physician groups, and others who attend our programs who are interested in learning more about the Worksite Center benefit, both for their own associates and employees, dependents, as well as how they can start a new business line to serve area businesses and compete with the multiple third-party service providers that are out there. Want to welcome you to this, and I want to say this is being recorded and will be available for everyone afterwards, as well as posted for members on the website. For those who are not familiar with the organization, the National Association of Worksite Health Centers is a 501c3 nonprofit group supporting employers, unions, and other sponsors of on-site, near-site, mobile, and virtual health and wellness centers around the country. We also have, as part of our membership, many of the leading and participating market players, both third-party players and healthcare providers, consultants, and others who are involved and interested in moving this market forward. We provide assistance and guidance and benchmarking about Worksite Health Centers. We support all of our members and others who are interested in this field through our educational programs like the one today, benchmarking services, purchasing support, networking, on a variety of information in our clearinghouse. We probably have the largest clearinghouse of data and information of anyone in the country relating to Worksite Health Centers. So I want to welcome you to participate in our organization and in future programs, especially our annual conference coming up September 8th and 9th in Nashville, Tennessee. The program today is structured to really allow you to have as much input as a participant and attendee as possible. They call you participants because you are to participate, which means you're to ask questions, you're to bring the reason that you're spending the next 3 hours or so away from your work. And so to bring you value, we want to make sure you have every opportunity to ask questions and get the information you really need about these topics. So as such, following each presentation, I will be literally calling on everybody on the call who is registered, asking if you have a question or comment or experience you want to share. And then we'll do so as well at the very conclusion. So the agenda for today is I'll be talking about the overall value and landscape of worksite centers. Then we'll have a discussion on legal, contracting, and operational issues of managing a center. We will then have a short 10-minute break for people. And then the remaining part of the program will be based on issues, challenges, and opportunities for hospitals in creating and managing worksite centers for their employees and area employers. There will be a variety of opportunities and for you to interact with our speakers today. So the purposes of today's program is really to provide hospitals and health systems, physicians, and other groups who are interested with an overview of the growing worksite health center movement and why employers are into this, what makes it valuable for them, what are their opportunities, what are the challenges for doing that. We want to talk about the legal aspects and the landmines that are out there, the things you need to understand if you're going to get involved in offering this benefit for your own employees or for others, and to give you different perspectives about this topic from people who have been experienced in doing it for a variety of parties and players. So there will be the individual presentations at the very start, and then we'll have broad panel discussions, and then we'll, as I said, we'll have a roundtable for you to participate at the very conclusion. Today, these are the speakers who will be joining us. So first, introduce Michael LaPena, owner of LaPena Group. Mike has held faculty positions in undergraduate and graduate programs and founded in healthcare. He was a hospital administrator. He founded his own consulting group, the LaPena Group, over 25 years ago to assist hospitals and physicians in the development of collaborative business models. And his firm was among the first in the country to get involved in worksite clinics and industrial environments. And he is also the author of the first and major book relating to worksite health centers. He is a co-founder, and a member of the NAWHC Board of Directors. Joining us also then is Stephanie Ickley. Stephanie devotes her legal practice to representing businesses in a variety of corporate, real estate, and healthcare matters. Within the healthcare industry, she focuses her practice on providing regulatory compliance and corporate advice to physicians, practice groups, pharmacies, on-site employer clinics, and health institutions. She's also a member and an officer at NAWHC. Also joining us is Matt Raymond. Matt is Executive Director of Business Development Employer Services for Froedtert Hospital and the Medical College of Wisconsin, Milwaukee. He's over 25 years of sales experience and leadership in healthcare, wellness, and health benefit sectors. Prior to working with Froedtert, he was the Director of Strategic Client Solutions for Quad Med, a subsidiary of Quad Graphics, which operates worksite centers around the country. And then our last speaker is Steve Zile. Steve is the pharmacist. He has over 25 years in healthcare experience and focused in a variety of areas, including pharmacy administration, population health, employee benefits, and risk contracting. Steve led the employer health division for a large integrated health system and was responsible for health promotion services, occupational health, workers' comp, employer clinics, and school partnerships. So with that, let's get the program started. So I'm going to talk now about the overview of what the Worksite Center industry and movement marketplace is all about, to give you a foundation for what is this all happening. So people ask, why do employers get involved in even offering worksite centers? Well, when you consider all of these activities that are currently being funded, supported, and offered by employers, the more of these activities that you can bring onto the worksite, the more that the employer can avoid having people leave their factory jobs, the call centers, the office, traveling across town, taking 3 to 4 hours, perhaps, to get the services, the more you can have a higher productive task force. And as more employers are frustrated with the cost and the variability of quality that they see, they get involved in what we call employer managed healthcare. And this is an effort to bring as many of these types of services that they're already offering and paying for the variety of vendors who have pieces of their data all over. The more you can consolidate that, integrate that, and coordinate it, you get higher quality, lower cost, greater integration of services, higher engagement, etc. And so these are many of the things that you as an organization can offer to employers to bring them all together. As I said, what we're finding also is not only are employers frustrated, but people are frustrated. Over 40% of people who use worksite centers don't have a personal physician. So they often look to the worksite center for their medical care, and it often becomes the medical home. Employers find that their centers offer easy daily access for medical care at little or no cost. Over 60% of employers don't charge anything at all for the worksite center services, labs, tests, whatever, drugs, whatever is being provided through that center. And they're really looking to find ways to integrate all this data, to find, because they, as I said, they've carved it out to so many different kinds of vendors that they really want to be able to have it in one location. And so they're looking for partners who can help them understand what's going on in their population, what's the prevalence of conditions, and where the high costs are. Clearly, when people get access to these centers, it often is the most highly rated benefit that's available to them. And it's something that they clearly are looking forward to. It's an opportunity to reduce unnecessary services like going to the emergency room or immediate care center for non-emergency conditions, but in fact, to be able to treat these things at the work site. And again, the thing that's most significant is that people see their doctors only once or twice a year for 7 to 12 minutes. And even with those with chronic disease, don't communicate often, but they're at the work site 1,000 to 2,000 hours a year. So there's a tremendous opportunity to educate, to motivate people, to really get them engaged in their own healthcare. And that's what we're trying to do with our worksite centers. Excuse me. So what are the major objectives? This is a survey, and I'm going to show several of these from a survey, benchmarking survey that NAWHC does with national consulting firm Mercer every other year to look about what's going on in worksite centers. So you can see this is where employers are. Patient access is key, especially during COVID. Many of the centers transition virtually all their services to a virtual or telehealth approach. Patient access is really critical. And even today, we're finding that the brick and mortar facilities are highly utilized. Less than 1% of employers decided to close their centers due to COVID, with people not being actually at the work site. So there's still a tremendous interest in having patient access and making sure that the quality is good, that we don't have low quality services. And in fact, the quality can be measured and is reported back. Wanting to increase patient satisfaction, the whole issue of recruitment and retention, making sure people like their work and like their benefits. As I said, increasing productivity, making sure people are at their jobs as often as possible and are happy with what they're doing. Reducing medical and pharmacy costs is really key. If you can keep people, again, at the work site, if you can reduce costs, if you could offer care directly and not be tied to a fee-for-service system, you're going to be much more able to reduce your costs. And again, it ties down to reducing, the people are healthier, and they're also not going to have so many accidents and injuries. And again, they can be treated at the work site if need be. So the continuum for employer for savings really moves along from occupational health services to offering acute care to offering primary care and fully a medical home. So the more that an employer can offer these, and more that a hospital or health system can provide these in a consolidated, integrated way, the greater the savings for the employer. You know, at the end of the day, a health center should not be another fragmentation of the healthcare system. It needs to be the core, the hub of everything an employer does. So all the vendors and all the benefits feed through the worksite center. And then the employer has all the data in one location, and all the providers are talking to each other and working together on behalf of the patient. When we look at the types of centers being provided, and we find that the vast majority are offered on site. And again, typically what we're finding is you need at least 1,000 to 1,500 people to make it worthwhile to have an on-site center. However, within any WHC, we have companies as small as 200 that bring a nurse on board a few days a week for basic counseling, blood pressure screening, pharmacy, drug management to help people with their diseases. So you don't necessarily have to be on site to be able to offer many of these services. Near site and shared clinics clearly are a growing trend, and what many employers, particularly mid-size and smaller, are looking for a variety of reasons we'll talk about a little bit later. But it's really, a lot of this is based on whether the employer wants to offer care, whether they have the space and they have the capital funds to support this. Virtual care is increasing, and it is really incorporated now into all of the on-site and near-site centers. And so it's really a key area for us to look at. When we look at the variety of players in the marketplace, we see there's three main groups. Well, about 6 to 8% of employers manage these centers all by themselves. They hire the staff, they run it, they oversee it. But the vast majority, over 60%, use a third-party vendor or service provider. And this is the listing of many of those that are out there. Clearly, there's close to 40 to 50 that I'm aware of myself, regional players, national players, et cetera. And there has been some merging and acquisitions within the marketplace as well, as you can see within this group. We also find that in most markets, though, about 18 to 20% of providers now are developing service lines for staffing and managing employer centers. We're finding that those provider groups that are really thinking about having a more integrated approach, that have the ability, have clinics surrounding a specific geographic area, really have the foundation for doing this. And many are beginning to recognize that employer centers are much more than just satellite center, but they're actually an opportunity to expand what a hospital or medical group is doing, to extend their practice out, to really re-engineer what they're doing. So when you look at the benefits of having a hospital as a clinical partner from an employer perspective, and a hospital, unlike a third-party vendor, is really a known entity in the community. It's a brand name that oftentimes people will trust and feel confident about where their medical records are and where they're going. Hospitals are perceived to have high quality and integrated care. And in many cases, the cost for an employer is actually lower than working with an outside vendor. Some of the challenges, though, is there's clearly a perception that a hospital will leverage the work site use it as a satellite to feed the mothership for more referrals, for lab tests, for services. And that patients in the clinic will be referred to other specialists, and there'll be more referrals. People will be leaving the work site even more. And so there needs to be a real understanding of what employers are what their objectives are and what the culture is for them to really want to reduce unnecessary referrals, keep people at the work site, have integrated care, and try to reduce costs whenever possible. The variety of challenges we see for hospitals as a partner. Many systems have geographic limitations. An employer may have a central core headquarters and then multiple remote sites, not just in the community, but in multiple states. And many hospital systems don't have that ability to be able to be in other marketplaces. So you really need to consider where you want to focus. Many local and regional hospitals, while limited in their ability to support it, though, if they have partnerships with other systems, if they are working with other medical groups, if they offer telehealth, there's opportunities to address some of these challenges that employers have. In fact, sometimes an employer will contract with a third-party vendor in the main location, and then perhaps local hospitals or health systems or groups where it has smaller locations. So there's always ways to look around this, but it's important that you recognize what some of these challenges are, and again, from a purchaser perspective and what the employer is looking for. Some other challenges is that some of them may not have the experiences or the knowledge. The third-party service providers have a real turnkey solution that they can provide. They work with employers and unions all the time. They can bring experience, they can bring benchmarking information, they can bring other partners to the play that employers already have and they're asking for. Clinics are typically run by hospitals, so it's fee for service, quickly generating volume. They're seeing a lot of patients. There's really not a lot of integrated care, particularly when we're talking about urgent care centers. And there's typically no integration with the broader experience. So again, you have to look at what are employers looking for and how to go about doing this. Some of the approaches that are primarily used by employers and their partners, as I said, most use a third-party service provider. A growing number are beginning to use some medical providers themselves, and some are still self-managed. About 47% are under a cost-plus type of payment approach. 44% use a capitated approach per member per month, something like that. We still have some doing fee-for-service, but employers want to get away from that. They really want a budgetable item when it comes to worksite center. They want everything bundled in a single kind of approach. They don't want any incentives for developing more unnecessary units of service. They really want to have everything covered into a single administrative fee, and then a buy-up for different kind of services as appropriate. Employers, many are still not measuring whether they're getting a return on investment, but we highly recommend that you really need an objective methodology for both the employer and their partner, whether it's a hospital system or a third-party service provider, which incorporates a comprehensive data aggregation, and not just the medical, but the pharmacy, the absence management, worker comp claims. Some employers even include performance data and other information. There needs to be an accurate accounting of what the costs are to implement the center, how to operate it, including any fees. And you want to compare it to what's the cost in the local community. What's the savings going to be? How can the employer be shown what those savings are? Those that have measured it have often shown increases as much as 3-to-1 return on investment. But we believe that it's more than just an ROI approach, that if you're serving an employer, a worksite clinic benefit, or any wellness type of benefit, you need to look at what we call a VOI, or value of the investment. And this goes for all kinds of programs. So it's more than just the return on the capital investment. It's also the measurement of patient satisfaction, or net performance score, reducing absenteeism, improving productivity, reducing not medical, but also pharmacy costs, and recruitment and retention. It also includes increasing engagement in employer other benefit programs like EAP, smoking cessation, obesity management, fitness programs, wellness programs. So there's a lot that should be measured, and a lot of data that needs to be gathered in order to demonstrate the value of this total investment, which can be in the millions of dollars. So when we look at staffing issues, what we find is that most of these centers are run by mid-level providers, nurse practitioners or physician assistants. Typically, there is a physician overseeing or coming to the practice on a periodic basis. A number of the service providers and employers want to have a physician nurse team leading their centers, but typically they're not very large. Usually there's maybe a physician nurse, maybe a medical assistant, a receptionist, perhaps one or two others. But as you can see here, as you get more mature and people start wanting more services, you start expanding the scope, getting into physical therapy, chiropractic, nutrition, wellness coordinator, medication dispensing, or actually a full pharmacy services, social work, massage. There's really no end in sight depending upon the space you have available and the type of budget that you're willing to do. But once this becomes popular, people will be asking for more and more kinds of services. As far as primary care, while many centers still offer primarily acute care and episodic care and occupational health, when we get into primary care, these are the kinds of services that these centers are typically offering. And more behavioral health is becoming one of the top areas, and particularly during the coming out of COVID pandemic. But we're finding that these things are typically offered. And again, it keeps people at the work site so they don't have to leave here. And many of the centers have partnerships with local hospitals and medical groups to offer some of these services. They also contract with laboratories and imaging services in the local community to try to get more of a preferred rate and preferred participation. Some of the centers are also beginning to offer dental care and vision care, eye care. And so, again, the more things that you can offer at a center that you can bring to employer, and you don't have to do it yourself. Many of the third-party service providers have strategic partnerships with the other vendors who offer these other kinds of services, but they bring it all together in a single consolidated approach. Now, who's the population? Well, it's not open to the general public. It's straight outside of the employees working at that individual site. They also try to include other of the spouses and dependents, which are many times some of the highest cost parts of their population. Employees from other locations will come in, contractors, people under COBRA, and even employees who are not under the plan. Typically, the health center is within the umbrella of the employer's health plan. So the health center is a network provider. And they don't bill the health plan for services. What they do, they often bill a $0 and counterclaims so that the health plan and the employer would then have a total view of all the services being provided to their population. So even though there may be people who are not in the plan, there still be providing coverage here. But it's also important to note that if you have HSA population, you have to charge them something. 60% of, as I said, of our centers don't charge anything at all. 40% still want people to be charged a minimal amount so that they make sure they show up for appointments. But in many cases, the IRS code requires that if people have a health savings account, they must pay some fair market value fee. And it could be as little as $10 or as much as just below the network provider rate. But for those people who are using an employer center that offers more than first aid and triage, they have to be able to have require a mandatory copay, and that's something you work out with your attorneys and consultants. So again, regardless of the approach that you take and the staffing you take, these are the key lessons we find for successful health centers. There have to be great provider staff, providers that understand the environment they're working in, and that they are unwilling, and that they do not want to be limited just to practice in the four walls of the center, but in fact, they're willing to go to the factory floor and perhaps even go to the ball field. In other words, you need providers that understand the population, the culture, and of the staff and of the workforce. Confidentiality is key. People will not use these centers if they believe their data is going to be released to the employer. So you offer occupational health, providing data currently to managers and supervisors about a person's status and return to work. You can't do that under primary care. So people need to know that you offer confidentiality and privacy. You also need to be able to offer services in a way that gets people to use it. These things do fail, and they fail because they're not communicated well, or people don't want to take advantage of it. So you want to be able to engage people, incentivize them, and offer low cost, offer state-of-the-art ROI tools. An employer wants to know what's going on. They want to see the value in their investment. You want to set appropriate expectations. Not all these things save money in the first year. Many take 3 to 5 years to do so. But you want to ensure that everything is integrated with the other wellness programs and vendors that an employer has. You want to be able to provide drug services so people can obtain their drugs, ideally from the center, instead of, again, having to leave the worksite to pick that up. And constant communications, constant visibility of the center, so can people recognize it's there and where to go. And to offer those employees that don't have providers access to medical care, and really focus on prevention and management. And so with that, I'm going to conclude here and just kind of go around the table. And as I said, ask if people have any questions about anything that I've covered before we move on to the next approach. So let me start with John. John Dawson, anything you want to contribute or comment to?
I think you did a very good job of providing an overview, so I've got nothing to add.
Great, thank you, John. Mary Vale, Mary, any comments or questions you have?
Not at this time, thanks.
Okay. Bojang Geliat, sorry if I mispronounced that correctly. Any comments or questions you have? John Zamates, John, any comments or questions you have? No? Alex Jordan, any comments or questions?
Nope, good frame up.
Okay. Cameron Klutfelter, any comments or questions if you want to add?
Hey, sorry, Larry, I'm good.
Okay.
This is John Zamitis.
Okay, thank you.
Yeah, Larry, I'm good too, thank you.
Okay. Melissa Wood, Melissa, any comments or questions?
No comments, thank you.
Susan Hogan, Susan, any comments or questions?
No, thank you.
Okay. Glenn, any comments or questions? Glenn Benjamin?
Hey, Larry, thank you very much. I got me one quick question in terms of contracting between the third-party vendors and the hospital systems. I'm not sure if it's appropriate now, but is there any sort of differences in the contracting sort of aspect from these providers versus the third party?
Actually, we're going to get into that in our next presentation.
Oh,
so let's hold off on that. So with that, I'm going to now move over to our next presenter. This section is on legal, contracting, and operational issues involving hospital worksite health centers. And so I'm going to turn over control to Stephanie. Stephanie, I'm going to let you have that. So if you'll put yours up on the screen, I'll take mine off.
Great. Thanks, Larry. Can you hear me?
I can hear you just fine.
Great. Now can you see my screen?
Yep, you can see the slides.
Perfect. Well, hi, everyone. It's nice to be here today. Thanks for joining. I'm Stephanie, and today we're going to be talking about legal and regulatory issues involving hospital worksite health centers. And Mike and Steve and Matt will be chiming in here too. So definitely, as Larry said, want to make this interactive. So questions and comments are welcome, as well as at the end of the presentation. So I work with a lot of different, well, a little bit about NAWHC, which Larry actually went over. But in working with health systems, you know, it definitely is a different framework than working with your traditional third-party vendors from the legal side, as we do see different regulatory considerations that we're worried about when we're working with hospital worksite health centers. And there's really two types of hospital worksite health centers that we work with. It's hospitals that are managing their worksite health centers for their own employees, of course, then also hospitals that are managing worksite health centers for employees out in the community, which for some of the health systems we work with, you know, is a great additional revenue stream too, because it's not as dependent for the health system on third-party payer reimbursement, like in Medicare or Medicaid, or Medicaid managed care, where there's issues with rates and payment in general. So it's been a really nice option for hospitals when they're able to start these programs and then really gain a reputation for providing quality care. So today, what I'm trying to focus on is not some of the traditional regulatory issues that I see with all worksite health centers, but some of the ones that are more unique to health systems. I know we've given legal and regulatory presentation and contracting for just kind of general health centers, so those are available too on the NAWHC website if you'd like to see those. So one of the big questions we get from the regulatory side is about employee benefits. Most of the time when I'm working with in-house legal counsel for hospitals, they're very, very well versed, of course, in HIPAA and HITECH and anti-kickback and Stark and, all those things, Medicare conditions of participation, but they're not thinking about the employee benefit considerations sometimes as much when they're starting worksite health centers for both their own employees and those out in the community. So there's really a few different things here. There's ERISA, COBRA, high deductible health plan and health saving account issues, which Larry touched on earlier, and then ACA issues. So I'm going to hit on these lightly and then happy to take more detailed questions at the end of this or even offline. So with ERISA, one thing that we really work with hospitals is just making sure that they understand that employers can inadvertently create a separate ERISA plan by offering employer subsidized standalone worksite health centers to employees. And so there's ways to avoid additional liability with the group health plan there. Sometimes I see employers limit access to employer subsidized worksite health centers to the group health plan enrollment. And you can also incorporate standalone services into your wrap document. So there's different ways to do that. But I guess what I would caution is, if you are a health system that is starting worksite health centers for the first time, whether it's for your own employees or others, definitely have really strong benefits counsel that's advising you the entire way, because it's going to impact risk management and liability concerns. It's going to impact the way you structure payment and whether you charge employees. And it will also impact even the language that you should be using in your contracts with employers. I also really encourage any worksite health center, hospitals too, that if they're providing worksite health centers to the community, so hospitals are providing it, to a car manufacturer in their community, that they're really heavily relying on that employer's benefits counsel too, because that employer is the one that is going to know their plan best and needs to work hand in hand with that hospital worksite health center to structure the health center. Sorry about that. Also, there are issues for high deductible health plans and HSAs. So one thing that hospitals, often and any third-party provider really want to do here is offer free care. So it's not free as in no one pays for it, but the employer will pay for it, maybe per member per month or something like that. And there's no issues with that when you have a traditional PPO or HRA plan. But if you do offer high deductible health plans with an HSA, there are certain requirements that you have to meet in order to maintain that HSA eligibility. And basically the short of it is that employers must charge fair market value for non-preventative services for employees with high deductible health plans and HSAs. And we get asked often what that fair market value is, and we get asked to opine on fair market value too. And there's a lot of different ways that can be determined, whether it's looking at standards in the community or in your region, whether it's looking at what others are paying for similar services, maybe within your health system. So I think there's a lot of ways to cut that. And to my knowledge, and Larry or Mike LaPena, you guys might have more insight on this. I've not seen a lot of IRS definitive guidance, nor have I seen any really penalties or issues for how fair market value is calculated for employers. Mike and Matt, I don't know if you guys want to stop here and kind of touch on the fair market value issue, as it always seems to be a really hot topic.
Well, I defer to Matt, of course. He's involved in it all the time. We do fair market value for a variety of hospitals and healthcare systems, and we have a high sensitivity to the compliance requirements. When we do fair market value, we generally take a look at actually pricing the stuff out comparative to other benefits in the community. And we find that we can justify a lot of this stuff based on wellness, preventive, and other areas that wouldn't be charged against fair market value. So we can come up generally with very modest pricing. By modest, extraordinarily cheap compared to other alternatives. It's also interesting now to compare things on a national basis to some of the costs associated with virtual care and non-traditional types of care. So there's a variety of things. As far as the compliance issues, we haven't seen any, and we're very sensitive to this. Stephanie, I know you are as well, to the literature that relates to the compliance factors that are being reviewed currently by the government or by other regulatory agencies. We follow AHLA and we follow the government feeds. We haven't seen anything attacking or looking at or critiquing the fair market value when there's a outside objective assessment of what's going on.
I think those are good points, and I'll offer a couple of more items. I can't comment specifically to fair market value and establishing that. However, some of my former colleagues that are participants on this call that are probably in the benefits advising and consulting world can weigh in on that. What I have seen in my experience is employers starting with some acceptable basis or fee schedule, and oftentimes we'll see employers or brokers start with a Medicare fee schedule, for example, which is generally accepted as market rates, and then apply discounts to that fee schedule based upon the scaled economies that a purpose-built or employer-sponsored health center brings to bear. The other thing I would share, just in regards to the journey for Frederick Medical College of Wisconsin, we have 20,000 plus or minus employees. We're one of the largest employers in our region, and we've had workplace clinics since 2006. And even though we're a health system, or despite the fact we're a health system, we offer workplace clinics for our own employees for the same reason that any other employer would. And so one of our initial objectives was to make sure that the benefit was free to all participants. There are some consequences to that. For example, we offer traditional PPO plans, but we also have high deductible and HSA plans. So one of the consequences is we've chosen to limit the scope of services that are available in our workplace clinics, so that we aren't creating a health plan, so that we aren't providing benefits beyond a significant value, and so that we stay below, ACA thresholds, for example. So that's, we'll have an opportunity to talk about some of those implications later, but I'll just offer that up as food for thought.
Yeah, Matt reflects on something really important. If we're looking in the fair market value community, you can see Medicaid rates, also Medicare rates, they're all publicly available. And those are generally so low, very low compared to anything that's commercial. And so you can make the claim that if doctors are accepting Medicaid and Medicare patients in the community, then they must be accepting those rates. So we don't think fair market value. We do fair market value assessments for hospitals, but we've never really been asked to follow through once we give the logic behind fair market value on a formal basis for an employer or for a provider. Darn it all. I wish we were, but we aren't. So I think it's a common sense approach. Stephanie gives good guidance here.
Great, thank you, Matt and Mike. So yeah, just, on the hospital side, be sure to have benefits counsel, brokers, whoever needs to be involved on the benefits side, and start that conversation early, because like Matt said, not only is it impacting how you charge, but it may impact the scope of services you're providing at your clinic too. Medicare and Medicaid is another one that I end up talking about a lot with my hospital clients. So this is something, of course, when I'm working with employers, typically this doesn't come up, or more traditional third-party vendors of worksite health centers, some of the national players, again, really doesn't come up. But with the hospitals, it's something that, they're always thinking about from a compliance standpoint. And so, most of the time employers are self-insured that are going to be working with hospital on-site health centers. So again, if you've got the car manufacturer, they may be self-insured or have a private insurance. So therefore, you typically do not have Medicare and Medicaid beneficiaries. Where this gets sticky, and I've seen this issue definitely more with hospital worksite health centers, but even some of the traditional ones, is when they want to see retirees. So you may have a worksite health center that's been around for, 5, 10, 15 years. It's got really high utilization. The employees love it. Well, when those employees retire and hit age 65, or, what, they may want to continue seeing that provider. And the provider may say, of course, I'll keep seeing you, right? I've been your primary care doctor. It's the patient-centered medical home now for years. Well, that becomes an issue. And so there needs to be a lot of thought into really what's easiest is just screening out Medicare beneficiaries and making sure you're not having those Medicare beneficiaries at the clinic at all. Typically, you won't have Medicaid beneficiaries there, or dual eligibility patients. But if you are not screening out Medicare beneficiaries, and I would also encourage hospital worksite health centers and employers to think about in the contract, should both parties agree, no retirees, no Medicare beneficiaries. But if that's not the case and you want to see Medicare patients, you need to think about, is the provider seeing the Medicare beneficiary opted out of Medicare? And if not, clearly they'd be enrolled in Medicare. So if they are seeing a Medicare beneficiary, they may have a mandatory obligation to bill Medicare unless they are an opt-out provision or follow some other pretty complicated procedural rules. And if they are not billing Medicare and they're not opted out, that could be a pretty significant issue for the health system. And so you just need to think through those issues. The other issue on the Medicare beneficiary side that we've had come up is, if you have a Medicare beneficiary that's being referred to the hospital for other services reimbursed by Medicare, you really start getting into both Stark and anti-kickback statute analysis. Stark, of course, has civil penalties. AKS can have criminal penalties, so very serious there. And so hospitals are really good at Stark and AKS compliance. Their attorneys know Stark and AKS in-house, I feel like usually very well, the ones we work with. But it's something, to think about here is there a Stark or anti-kickback statute analysis that needs to be analyzed? And do we need to be looking at any of those safe harbors or OIG opinions to make sure that this is structured? Do we need to make sure that the physicians are being paid fair market value? If mandatory referrals are required, do we have the language in there that says, you can refer patients internally, except if it's not medically advisable, if their insurance provides otherwise. So again, not a huge issue that we see a lot with on-site work centers with hospitals, but one that everyone needs to be thinking about, because there can be significant liability there. Both, even internally, if you have a whistleblower claim on the AKS side. The other thing I want all hospital worksite health centers to be thinking about is the state anti-kickback laws. So even if you are not seeing Medicare beneficiaries and you do not think that Stark or AKS is an issue with your worksite health center, most states have their own anti-kickback laws that are not part of the Medicaid reimbursement scheme. So for example, in Indiana, we have one that basically says, a physician cannot be paid for making a referral. And so we need to make sure too that any structure for referrals fits within those state anti-kickback laws. And that goes for not just hospital worksite health centers, but really any. And those would not be an OIG investigation, but those would be an attorney general investigation. A lot of times the way we see those play out though, is if there is an allegation of a state anti-kickback law violation, it also turns into looking at maybe your Medicaid program, for in Indiana, for example, through our fraud control unit, and other implications too. So just something to think about. Mike or Matt, do you have any thoughts? I don't know, Matt, if you guys allow retirees or Medicare beneficiaries to use your clinics, or if you know, yeah, most people don't. It gets complicated if you do. Mike, have any thoughts on this? Oh, you're muted, Mike.
Hey, Mike, you're on mute.
Mike, you're muted.
Sorry.
There you go, Mike. Yeah. Okay. So
Yeah, we haven't had much of an issue with it because the Medicare COBRA and retiree issues are generally turfed off to another provider in the community. And the national vendors, my experience, shy away from this because they don't have much, I guess, experience with this or comfort with it. When we ask hospital counsel, generally hospital counsel steers people away from it as well. I haven't seen a state anti-kickback issue arise or any of the Stark or AKS stuff. We do have contracts when we look at providers that give clear indication to the provider that they may refer any place, even though we may not be dealing with Medicare patients. We don't want to have any confusion that there's channeling or referral for anything except quality and efficiency issues. Access perhaps is another factor. So I think it's something to be concerned about and aware about. But if you ask the compliance officer within a hospital, you're going to drag this program into a long process of review, I think, to no end.
Yep.
You really need to have a knowledgeable attorney that deals with AKS and Stark dealing with it to help you through it.
Yep. And again, if you're avoiding the retirees, it's going to be a lot easier. One thing Mike brought up too, I want to mention is COBRA. So that requires, after the employee is terminated, continuation of care in most circumstances. I would say I have seen hospitals have an easier time dealing with COBRA implications because instead of allowing the employee to come back to the on-site clinic, they have other providers, very nearby to provide the same type of care. So COBRA seems to be an easier one to work through when you're a hospital worksite health center. Surprise billing laws, I'm going to spend maybe 1 minute on this. This is something that if you're in healthcare right now has been a very, very hot topic. It is something that I am not seeing a lot of worksite health centers really start to deal with, and they may not need to. But I've seen the hospitals do it. And I actually know some hospitals that have worksite health centers that are choosing to basically, because they're complying with this throughout their health system, they're doing it within the worksite health center. So a good faith estimate basically requires you to post a notice of a patient's right to request a good faith estimate. And the reason we don't see this much in traditional worksite health centers is really you have to give it to uninsured and self-pay patients. But of course, for a worksite health center, it's mostly insured patients. So the one thing I wanted to focus on here, and I just want to warn hospitals, is even if you think the surprise billing laws do not apply to the worksite health centers, we have found that state laws may require a good faith estimate to be given to an insured patient, which when requested. And so, you need to be looking at the state good faith estimate requirements too. And it's a little interesting, right? Because there may be no estimate to give if the patient is not paying for those services. So just wanted to throw that in there as something that I'm getting a lot of questions on from worksite health centers, especially with hospitals, as to applicability. I want to move on to one that is probably one of the most important, I think, for hospital worksite health centers, and one that I think has been a little tricky. And so, hospitals traditionally just have records for their patients. But here, we're going to have records for employees versus records for patients. And so we always recommend that you either have two separate EMRs, one for your patients, traditional patients in the hospital, and another for your worksite health center if you're providing that to your own employees, or at least a firewall, especially for occupational health records. That's where we really want to be careful about the two mixing. For hospitals, they're of course very good at compliance. They understand OSHA record keeping requirements for their own employees, but do they understand that for other employers if they're providing this service out in the community? And really who's responsible for those record keeping requirements and retaining those records? For traditional, inpatient stays, of course, the hospital is going to be required to retain those records, but under OSHA, it's the employer. So sometimes I have seen when hospitals are providing on-site care for employers in the community, there's a bit of a push and pull as to who has those OSHA record keeping requirements. HIPAA and information blocking applicability is important to think about here with occupational health records. Because hospitals are covered entities under HIPAA, even if they're providing occupational health services, those occupational health records may be considered or will be considered protected health information under HIPAA. Whereas if you have an occ health doctor that's more cash pay, it's not a covered entity, they're not as worried about HIPAA. Information blocking is another one that's been a really hot topic lately as it relates to occupational health records. So under information blocking rules, any healthcare provider, all healthcare providers have to comply regardless of if they're a covered entity under HIPAA. And I actually sat in on a webinar with the Office of National Coordinator and specifically asked the question about applicability of information blocking rules to occupational health records, and they did not answer. And so we are advising hospitals and all third-party clinic providers that they need to be complying with this for all types of records. Another thing that I think can be a bit of a hard one for hospitals that have not worked with on-site employer clinics before or led those is applicability of ADA and OSHA privacy requirements and the consideration of the employer being able to perform medical examination of employees and how that really comes into play there from an ADA and EEOC perspective. So again, when we're thinking about legal and regulatory, I would urge hospitals to think beyond just the HIPAA rules and to some of these other privacy requirements.
Stephanie, this is, I can make a couple of comments on your prior slide. We may end up talking about this later in the presentation, but for the attendee participants that are with health systems, this is really a strong consideration. We've had workplace clinics since '06. Obviously, we have internal occupational health for our staff as well, and those are distinct clinic environments. So within the workplace clinic, we can do some first aid and some triage, but it's not intended to necessarily serve the role of the internal occupational health clinics. Likewise, we also manage external occupational health or retail occupational health for employers and members of the community. And for many of our on-site clinics, we do differentiate between primary care services and occupational health services. So when we're on-site in an employer, we may also have two different EMRs that we're deploying. One EMR for the primary care services and then an EMR for the occupational health and medicine. There are some interesting things that might blur the lines. If you're an employer and you require a flu shot, right? Should that flu shot be in both systems or should it be in the occupational health system? Many of you also dealt with the same thing for COVID vaccines. So those are just some things to make sure that you're aware of and you're dealing with your compliance and risk people appropriately.
Absolutely. And there's some, oh, go ahead.
No, I'd make another comment. And Matt brings up a good point. When we're doing a planning session with a hospital or health system, generally the OC health people, which are an important component of employer services, are on campus and in the meetings and involved in the planning, it's always, I have to say it kindly, an impediment because they feel that their discipline should be providing this. You need a separate management structure that understands primary care and the delivery of primary care, not just a separate EMR. And that mindset is so important to employers. They understand safety and healthcare and where you get your protective shoes and hearing aid components, but this is all about primary care. So in the planning process, wonderful to have them at the table, but they can't lead the charge.
And Stephanie, if I could make two quick addendums. One on our first bullet point, and I think Matt touched on this, it probably is preferable to have a separate EMR, but if you do not, if you put a firewall in place, remember that there are very different requirements for record retention. And in occupational health, that record retention is very, very long. And then secondly, Matt brought this up about where do you put things? I know a lot of health systems have had their employees consent. When they get like a flu shot that's going to be in their occupational health record, they will consent for it to be added to their primary care record so that way the primary care physician has visibility into that, and that helps with quality metrics and those type of things as well. So there are ways to work your way through this, which I think is kind of the point for our participants, but it is something you need to keep in mind.
Yeah, Steve, those are really good points. And actually one thing when we're doing like a tabletop exercise to start a new Worksite Health Center, we will actually create a grid sometimes that goes through all the different types of records, like everything, records you wouldn't even think about, right? All the OC health records, the hearing test, everything, the primary care, what laws apply, who's responsible for retention, how long you have to do it, what authorizations you would have to have released. And they're pretty comprehensive, but they're really, really, really helpful. So definitely something I would recommend doing. So one thing Steve just hit on too, record keeping requirements as far as retention periods. Really, really, really important here. OSHA can be a very long time. And who's responsible? Is that the hospital or is that the employer? Versus, your primary care records, there's a state law record keeping requirement for providers, typically 7 to 8 years. You may have separate record keeping requirements for payers. I've seen longer ones for workers' compensation claims. So that's another thing. It's not just the federal and state requirements, it's contractual. Who owns the records in primary care would be the provider. But right, when you transition, we'll talk about that. We talked about HIPAA and information blocking. Okay, EAP, that's a really, really big one that I have seen trip up both hospital clinics and more traditional providers. So if you are providing an employee assistance program in a Worksite Health Center that is preventing substance use disorder treatment and counseling, you are also going to have 42 CFR Part 2 compliance, which has very, very, very strict privacy requirements for those records, much more strict than HIPAA, right? And so if you have a patient coming in that's receiving counseling for substance use disorder and they qualify as a Part 2 entity, which is very defined in this regulation, that's a whole nother set of privacy guidelines. And this can be a little tricky too for a hospital, right? If they are providing that in-house in the Worksite Health Center, but they're also providing occupational health issues. You may have, I've seen cases where managers are calling and like, I want to know how this person's treatment is coming. So just thinking about all that is important. And then lastly, mental health records are going to have even separate requirements under state law, and then also minors. So if you are a Worksite Health Center that allows dependents to come, you need to have a really good compliance policy built out for who can access those minor records and what are exceptions to that, right? If you're prescribing birth control or other things too, are there state law exceptions where the parent cannot access those records? And then what rules do you have set up in the EMR to make sure there's compliance with that? Okay, real quick, under HIPAA, there is an exception for a disclosure to employer that I always advise Worksite Health Centers to comply with. And so typically, if a covered entity, so a healthcare provider, which hospitals are going to disclose health records to the employer, they need to have a HIPAA compliant authorization from the employee. They cannot disclose those otherwise. However, if the hospital or covered entity is performing services at the request of the employer, and it's specifically related to medical surveillance and work-related injuries, and the protected health information only relates to medical surveillance and findings that that employer needs to comply with law, such as workers' compensation laws or OSHA, there is an exception for disclosure. In that case, the covered entity or hospital can just provide written notice to the patient that the protected health information is related to workplace surveillance or illness and made it be disclosed to the employer by giving notice to the patient at the time the healthcare is provided or by posting notice in the Worksite Health Center. So I advise all Worksite Health Centers, regardless of if you're a hospital or more of a traditional national provider, post that notice in the Worksite Health Center if you are going to be providing occupational health services. I have a lot of clients that still get written authorization too. But right, if that written authorization is accidentally not obtained and you have that notice and it's for medical surveillance, you're not going to have a HIPAA breach then. And so this is a really important one. But I've also seen people try to rely on it too heavily where someone came in for an occupational health issue, but they also, are feeling lousy and they have the flu. That turns into a primary care visit. That part can't be disclosed. So again, really segregating those records is critical.
Sorry, could you say that again?
Oops, my watch is going off. Let's see here. Last thing that we have seen, employers start to really think about hospitals. They may or may not know this is out there. The Department of Labor just issued cybersecurity guidance about maybe a year ago now that's applicable to plan sponsors and fiduciaries. The good news is for hospitals running worksite health centers, if you are following HIPAA, you're probably complying with the DOL cybersecurity guidance. But again, I would look at this because if you are working with worksite health centers and employers in the community, that employer is going to be a plan sponsor and they're going to have their own requirements under the DOL guidance, in addition to HIPAA and everything else. And you're going to want to make sure that you're well-versed and understand and are prepared to talk about how you're complying with this. Okay, pharmaceutical considerations. I'm glad we have a pharmacist on the phone for this one. So this is another area that Larry mentioned in his introduction that can be a really nice advantage for on-site health centers because they can have on-site dispensing there without often having a traditional pharmacy on site. Because in most states, but not all, physicians and in most states, nurse practitioners and physician assistants can actually engage in dispensing of pharmaceuticals without having to have a licensed pharmacy. And so that's something from the beginning when you're planning, you should really think about, does that on-site provider dispensing work best where you partner with a company to provide the 30-day prepackaged drugs that your providers can dispense, or do you do a traditional licensed pharmacy, which may be more expensive, but maybe has some other advantages too. Let me kind of get through here. So these are some of the issues that you really need to be thinking about when you're looking at how you're going to handle the pharmaceuticals. And although hospitals of course have their own pharmacy supply chain, some may be part of the 340B program, we have started to see a lot of hospitals work with a pharmaceutical repackager or wholesaler to supply the drugs to the hospital for various reasons. There may be certain medication rebates and more transparency. There may be more data analytics on medication adherence and utilization. But these are just all things to think about. And one of the big ones too is if you are running kind of an on-site clinic that has medications on site, thinking about who owns that medication upon clinic termination, and can that medication even be transitioned between hospitals or providers? A lot of times that's prohibited under the wholesale distributor drug laws in each state. Steve, I don't know, Mike, Matt, this is a big one, pharmacy. So I feel like there's probably some other commentary that's much more real life and practical here that you want to jump in on.
No, I think you did a nice job. I would offer one kind of an addendum to the information you've already provided, and it goes back to that kind of traditional pharmacy versus provider dispensing. One, be very sure you understand the provider dispensing rules in the state you're operating in, because they're wildly different from state to state. But the other thing is we're seeing sort of an expansion of people's interpretation of provider dispensing to include where they're sending medications out of the health center. And that is clearly not the intent of provider dispensing. Those are intended to be handled within sort of the four walls of the health center that's being operated. So I would caution people, if you see that practice sort of out in your communities, to be very careful before you participate in that, and make sure you do have good legal counsel before doing so, because I think that's a very murky gray area for you.
Steve, can you give an example of that, like what you actually mean by that? I want to make sure I understand.
So let's say a patient comes in and they are diagnosed with high blood pressure. So they receive a high blood pressure medication right there at the point of care. They take that home. That's fine, because the provider is providing that medication in the location of care. And then let's say that the patient does well, their blood pressure is fine, but they don't want to come back to the health center. So then the health center would mail them a sort of sample, if you will, or a medication from the health center as part of provider dispensing. And that is where you've kind of crossed the line. A pharmacy can do that because they are operating under the licensure and the rules of being a pharmacy. But the vast majority of health centers are not licensed as pharmacies. And if you are, you would be required to have a pharmacist on site. There's different security regulations. There's a whole different set of labeling requirements. There's a whole set of storage requirements. There's lots that comes with that most health centers are not set up or prepared to provide.
Yeah, that's a good point. Typically what we see when we're setting up these arrangements and working both with the on-site employer clinic, but also sometimes the pharmaceutical providers, is the provider can dispense the 30-day supply, but then if there is follow-up, that will be dispensed from the mail order pharmacy that contracts with the provider. Steve, I don't know if that's how you see that type of arrangement work more frequently, if the drugs are being sent directly to the patient's home.
I think there's a variety of approaches, but you're right. It typically then involves a licensed pharmacy providing that follow-on service. And the nice thing about that, and I'll be very brief, but the nice thing about that is it does free up your health center staff to do other things. I mean, it's great when you provide the medication kind of the first time, but there's kind of diminishing value from a time standpoint after that. So there are things where you can get value without it being done at that.
Yeah, and I would say too, Steve made a good point. There are some states, I mean, the laws are different in every state. So there are some states a traditional pharmacy works better and you have to have it, a licensed pharmacy on site, right? Because you can't have the physician dispense, or if the physician or nurse practitioner or whomever can dispense, it's a very limited formulary. And so that's why I have seen in some states employers opt to go with the licensed on-site pharmacy that does require a licensed pharmacist on site then during normal hours. Matt, do you have any thoughts on that? How you guys handle that?
I would just say that we're very cognizant of the issues and the risks that both you and Steve just covered. We do dispensing at probably most of our employer-sponsored workplace clinics, and typically it's at the request of the employer. The formulary is typically customized from one employer to the next. Often that's led by the benefit consultant to make sure that it's consistent with any contracts that they might have with either their TPA or their PBM.
Perfect. Yeah. One other thing that I wanted to touch on here is I've had this question a few times, and I'm not going to go into 340B in detail at all. But if you are a hospital that's considered a covered entity under the 340B rules, and those are certain categories of hospitals, such as disproportionate share hospitals or sole community hospitals, rural referral centers, or critical access hospitals, you may be participating in the 340B program. And I would just really caution you to think about the 340B program and how you're using those drugs based on the definition of a patient. And so again, that's a whole nother seminar that would be really complicated. But since this is focused on hospitals, I wanted to throw it out there in case we have any hospitals that do participate in the 340B program, that really needs its own regulatory analysis if you would choose to go down that road. But I've really not seen anyone do that. They typically source those drugs separately for employers.
Yeah, I'd make a couple of comments. When we do our analysis for the employers for their costs, this always comes up as the most important, highest yield square footage that they could apply to a service is to control the pharmacy costs. And I ask two questions and make a couple of different comments. We've not ever seen a hospital that's looked at their 340B program that can dispense outside to an employer after they review it. So Stephanie, I think that's a good call. I'm glad we had a slide on that. I'm glad we had a very, very wordy, complex, scary slide on that, because that's a problem.
Yeah, it's like a red line. Like, don't do it. Or if you're going to do it, you better have really, really good legal counsel that's going to make sure you can do it. And I would caution against that. So
Yeah, this slide says see your lawyer.
yeah, see your lawyer. Call your lawyer that knows pharmacy and 340B drugs.
They have to know 340B. You can get away with it with your own employees, but I'm not sure if you have a vendor involved that you're going to be able to do that either. The question I had, especially for Steve, is we do have patient counselors and patient coaches, and we've got some employers, and I frankly am in favor of it, that just say, look, here are the different places you can get your pharmaceuticals. And then here are some Canadian firms that have recognized pharmaceutical services. Mail order, when they're paying for it themselves, the cost differential is dramatic. So I know that doesn't comply with any pharmacist's idea of how life should go, but the pharmacy PBM approach sometimes just doesn't give you the cost advantage.
I had a question for Matt and Steve. Could you talk a little bit about the hospital's relationship with the employer's PBM during this this kind of service? Because hospitals might want to use their own supplies from their pharmacy, but how does it work in the real world?
Well, I think hospitals have to be, that's such a case by case scenario in terms of where the hospital's located and
where they get their
hospital they are and those type of things. I would say a lot of times it's actually easier, even for health systems, even though they do have their own pharmacy, to actually use a vendor service for this, because the record keeping and just the workflow is so much different than what you're dealing with if you're a health system pharmacy. A lot of times this can kind of get in the way of the work that they're doing for inpatient pharmacy or their oncology health center clinics, or those types of things.
I think that's what I would echo as well. So Freighter Health has an entire service line dedicated to pharmacy. So we have Freighter Pharmacy, which has a specialty pharmacy group, a mail order group, infusion. So it's a very comprehensive pharmacy platform. However, when it comes to employer-sponsored workplace clinics, we use a third party. So we use one of the vendors that's a NAWOC member that's built for being in the environment that Steve just described. So even though we have tremendous pharmacy resources, we outsource and use the third party when it comes to employer clinics.
Yeah, that's what I see a lot of hospitals do too. So I think it's an important one to think about. We might talk a little bit about that more during operational discussion. So I want to go on to direct contracting with employers. So again, there's a lot of other regulatory issues, and I'm happy to talk about that offline, but I want to spend a little time on the contracting. And so we've seen a lot more direct employer contracting with some of the high profile employers such as Amazon that you're going to hear about. I think in the real world, sometimes this is a little less common, but what I am seeing is hospital systems getting interested in this. So hospital systems contracting with local school systems, hospital systems trying to contract with different chambers of commerce, right? That aggregate multiple employers to a worksite health center that's shared, working with, again, the car manufacturer. And so I think this is something that hospitals should really consider, because again, I'm on the legal side, but from what I'm hearing when I'm sitting in on these meetings to help with compliance and regulatory and contracting issues, is that this is another stream of revenue that's not dependent on that Medicare and Medicaid reimbursement. And so I've seen different approaches to this, like a partnership with a TPA and buying from an employer, or direct arrangements where it's literally the contract between the provider and the employer. So I want to spend a little bit of time talking about the contracting. Mike, we spoke at a whole seminar dedicated towards this. So if you really want to get into the weeds on contracts with employers, I think that's available on the NOWIC website. So this is hitting on some of the highlights and things that I think hospitals need to think about. So one thing that I think the more traditional national vendors are really good at is tracking utilization and other metrics. I think if you're a hospital that for the first time is getting into this game, you need to really think about that, right? How are you going to compete with those vendors and be able to track that utilization and other metrics? So what are your performance guarantees? How are you managing chronic conditions? How are you determining the return on investment? And I know, Larry, you've got a lot of thoughts on return on investment too, I'm sure you could talk about. And then I'm not going to spend any time on the last two since we've talked a lot about that, but that's a big one. And I'm not sure if anyone, Matt or Mike want to talk a little bit about the importance of those performance guarantees or being able to track utilization and what hospitals should be thinking about when they're getting into this.
Well, I can only say that every time we work for an employer, the question of how much is this going to cost me and what's it going to net for me as the employer becomes paramount. They, of course, want to have all of those positive things that Larry was talking about for their employees in their workforce, but they want to know the cost, the return, ROI, and if there is a contract that they're working on with a vendor or a hospital, there are generally performance standards that relate to bonuses or penalties. So knowing how to frame these, it's not complex, but it's complex for a hospital that's never been through it before, that's dealing on, DRGs, fee for service, and maybe some limited risk sharing contracts. And the vendor community doesn't really understand risk sharing and the definitions that go along with it. All apologies to the vendor community, but here's an opportunity for hospitals. If you want to have a risk sharing with a captive beneficiary or workforce or population, this is your chance. Risk sharing that the vendors bring to the table are generally performance guarantees and bonuses for performance that might be predicted. Risk sharing, of course, the hospitals understand and the employers understand to be the change in the cost for healthcare curve or controlling the cost for healthcare increases and sharing the margin that the employer would have had to otherwise pay in the marketplace. So it's a great opportunity to be creative for hospitals and health systems that I think the vendor community probably is maturing into, isn't there yet.
Yeah, Matt, do you have any, I don't know how you guys handle utilization.
Yeah, all good points. And, I think when we get to the Q&A, there's probably going to be a discussion around for health systems, what are some of the hazards or things to be aware of if you're going to get into offering workplace clinics. And I look at the kind of the title of this slide, which is the hospital track. So if you're a health system and you're not directly contracting with employers, this speaks to the internal operations of working with your IT departments, your compliance departments, your risk departments, and your legal departments, because you're going to be challenged to share and report data to entities in a fashion that you've not historically done. So all health systems are experts at submitting claims that are driven by CPT codes and drive reimbursement. When we're operating a workplace clinic, we're not talking about, reporting claims in that way. We're reporting claims from an encounter standpoint. So there's typically a lot of discussion and education for those other colleagues in those other departments to help that you all are going to need in order to have a successful opportunity to offer workplace clinics to employers.
Yep. A couple of other things here is just, analyzing your contract with employers if you're providing this to outside employers. And we'll get to a case study real quick here, but really thinking about the liability considerations. So indemnification, limitation of liability, any warranties, releases of waivers, and lastly, joint employer, which we'll touch on more. But, on the indemnification side, hospitals, of course, are going to have their medical malpractice insurance and their professional liability insurance and CGL and whatever else. But, what are you protecting that employer from? And likewise, what is the employer protecting you from, right? Because it really is different than your traditional primary care fee for service. I've also seen a lot of healthcare providers try to insert limitation of liability clauses based on, let's say the fees in 1 year accrued when they're contracting with employers, and thinking about what are the carve outs on that, if any, right? We have a lot of employers who push back and say, when it comes to cybersecurity issues, when it comes to issues covered by med mal insurance, why are we limiting that liability? But we also, on the flip side, have, the healthcare provider that says, well, we can't have an unlimited liability contract. So that's always, I think, where we get into a lot of discussion on the pros and cons of that too. I want to give an example here of why this language actually matters. It's a little different than what hospitals would be thinking about. So if you're contracting with employers, you may be doing certain OC health services, such as pre-employment screenings or worker compensation examinations, POET, all that, post-offer, pre-employment. And so if you're doing that and you're sharing that information with the employer, which you're allowed to do because you have a patient authorization, or you're allowed to do under the HIPAA exception if you're posting the notice and it's related to medical surveillance, it's necessary to comply with law. What does the employer do with that information? So here the plaintiff suffered a work-related injury and filed a workers' compensation claim. The plaintiff had a functional capacity evaluation, and this was by an on-site clinic, a third-party clinic. And the medical director determined the employee could only return to work with restrictions resulting, and that resulted in termination. So basically, since that medical director of the on-site employer clinic said the employee could not return to work fully, but with these restrictions, the employer fired that employee. What did the employee do? Well, the employee filed a lawsuit and filed a claim for retaliation and violations of the ADA and FMLA against the employer, which makes sense because the employer is the one that decided to terminate that employee. They also filed a lawsuit against the Worksite Health Center. And so, of course, hospitals are used to employee claims because, they have employees, they fire employees, there's going to be discrimination claims. But what about when you're contracting with an employer fires an employee based on, medical information you gave, and now you're dragged into that lawsuit. So here, that employee claimed that the employer held that worksite health position out as an employee of the employer, and that because the worksite health clinic and the employer and employee were so integrated, they were considered joint or integrated employers. So I'm happy to, I have a couple of cases like this I've pulled. I'm happy to send those to anyone if they're interested. I find them interesting because I think as a hospital or any third-party clinic, right, that's where you're going to be thinking about this indemnification language. So if you get drug into a lawsuit by an employee that, had to do with the Worksite Health Center only because of the findings you made, but those are medical findings, those are not findings related to whether that employee should be terminated. Will that employer defend and indemnify you in that lawsuit, or should they even have to? So, things to think about there too. And lastly, on direct contracting, and again, we can talk about a lot of other issues if people have questions on this, is how is clinic termination and transition handled? This is another one where we just did a webinar on this, just a few weeks ago. But things to think about, especially if you're on the hospital side, is do you have a non-compete for your providers in their employment agreement? So for example, if you hire a physician to go work in a rural community in an on-site clinic, and that contract is terminated with the employer, can that physician stay and work directly for the employer or a new clinic manager, or are they prohibited in an employment agreement? And hospitals are very familiar with non-compete contracts for physicians. We see them used often. But also, is there a non-compete or non-solicitation in the employer contract where that employer cannot go hire that physician? I've also seen it where hospitals let that physician move on and go with that employer or the next clinic manager. I've seen some hospitals that have been very great partners in that regards to ensure continuity of care. Some other issues: who owns the equipment and pharmaceuticals? What are the notice requirements for giving termination? Are there termination fees? I have seen those in contracts with more traditional third-party clinic managers. And then who owns that IP? Let's say the clinic is named after the hospital. So it's the, Frederick Health Employer Services Clinic for an employer. Do they get to keep using that name? Probably not. That's, the name that the hospital owns, right, Matt? So thinking through that is important too. I know Mike, Matt, Steve, you guys may have a lot of thoughts on, contract issues and things I didn't hit on, or you want to expound on there too.
The only thing I'd add as part of your list is the ownership or transition of software licenses. So if there's a need to be seamless in your care, you're not sitting there setting up a new EMR or a new database, et cetera. And then the ownership and conversion of the data. To have the data handed to you in a paper form or faxed to you is one way to do it, I guess. But to guarantee the transition in a data usable format is the important part that I think is necessary for a contract.
Yeah, and with hospitals too, when you think about the EMR you're using, if you're using, for example, Epic for your traditional patient care, that's certified under the 21st Century Cures Act. It complies with the new interoperability rules. But does your EHR for occupational health records do the same thing? Because if it is, one of the requirements under those new laws is an automatic export tool. And Mike, like you said, so they can't print off a bunch of papers, but they have to export those and be able to do that to a new EMR basically automatically. And so, that's something to think about too, is again, what's that interoperability, like Mike just said, when you're transitioning.
I would mention also, and ask for Matt to comment on it, because many different vendors and hospitals have other ancillary agreements. Example would have been pharmacy, which we talked about, but physical therapy and maybe a supplier agreement, purchasing arrangement or whatever. All of these things are created within a network of support functions. And the question is, can you transport those or transfer those, or do they have to be all recreated?
I haven't experienced this, or we haven't experienced this, fortunately, so that's good news. But what I would offer is that, for example, all of the staff within Workforce Health are dedicated to working exclusively with employers, even though our providers in Workforce Health are not shared across the health system. The contracting and the oversight process is consistent with that of the rest of the health system. The environment that I'm in is also a little bit different, where I'm only operating workplace clinics in my primary service area. So if a workplace clinic were to dissolve, we would have an opportunity to redeploy that staff to other parts of the health system.
Well, that is all I have. If you guys have any legal or regulatory questions, please feel free to email me anytime. Happy to chat. And Larry, I'll turn it back to you for discussion on some of these points in the next session.
Great, thanks very much. So let me take back the control of the screen if I could. And let me, again, as I said, go around the table and see if people have questions. So let me start out then with Alex Jordan. Comments or questions that you have?
Yeah, great overview. Appreciate the content speakers put together. I do have one question in regards to joint employer contracting. Are there any preferred recommendations on the contracting? Is it contracting with each employer who's accessing the the health center? Do you do an umbrella contract? Any thoughts or I guess commonalities you've seen in the marketplace?
Yeah, so Alex, what I've seen, if you have what I think you're asking, like a shared clinic, so maybe the hospital runs a clinic that several employers can go
Yes.
to.
Yep.
We usually have my clients have a separate contract with each employer. And so, when you're doing those contracts, there are some provisions, right? If the one employer pulls out, does that change the cost? Does that not change the cost? If one employer adds, let's say through a merger, a large workforce, can we still handle that utilization, the hours? But I definitely see individual contracts. I don't see umbrella contracts. The only time I've seen any type of umbrella contract is when the health system or third-party providers contracting with like an industry group that allows its members to use the clinic, and that gets into some really interesting benefit issues too. And on the joint employer side, I would say really strong language about in the contract between the third-party provider, the hospital, and the employer, language that basically all employment decisions are the independent decision of the employer, and we have specific language we put in that goes into even greater detail about that as far as termination, hiring, firing. And on the joint employer side too, it's really how do you hold yourself out, right? So are your employees, the doctors and the MAs and the clinic staff wearing, shirts that say, like the car manufacturer's name in there, they're pretending like they're an employee of that employer, or are they actually employees of the hospital? And everyone knows that. So a lot of it is optics too, and decision making. So it's a combination, I think, of operations and contract protections.
That's helpful. If clients kind of come in and come out, obviously pricing is immediately impacting the whole group. Does that trigger entire contract rewrites or more amendments from your perspective?
So the way I like to help my clients set up contracts, but again, I'm outside counsel here, so people do it all different ways, is on the pricing. We usually have that on an addendum or a statement of work. And so if the pricing is changing, there's a mechanism in the master services agreement to do that through an updated statement of work or change order, where we're not having to amend the whole contract. I really think it's a good thing to try to avoid putting that type of detail in the MSA itself, because amending the MSA is a lot more cumbersome, frankly, with in-house and outside counsel and all the different parties as opposed to an SOW. But if you are going to have mechanisms for pricing change, like employers coming in and out, or I've seen certain thresholds, if it exceeds 1,000, 2,000, 10,000, 40,000 employees, those thresholds and the mechanism to change the pricing need to be very, very, very clear and well-defined, or that's a way to have a really good dispute with a client and an unhappy employer when you're trying to change pricing, midway through. Usually I also see guarantees on pricing the first year, 2, 3 years, whatever that may be, other than we try to build in some caveats, just like, if you merge and you take on 10,000 new employees that weren't originally anticipated.
I would just comment, we do some of the financial modeling that ends up as an addendum to a contract. And normally when we see the employer, critical mass changing and having it affect pricing, it's because there was some sort of capital part of this that was shared by employers, like a new building or something like that, and fixed costs that are not able to be scalable. So if we try to parse it between scalable and non-scalable, and then as Stephanie said, have something like a 2-year frame, which with the exception of bankruptcy or something like that, is stable for all employers, because the employers need some sort of stability in their cost profile for these things. So that's my experience based on maybe mostly industrial parks, stuff like that.
Okay, thank you, Alex.
Very helpful. Yeah, thank you.
Sure. Bojan Galiat, Bojan, comments or questions?
No question, just definitely want to reaffirm the comment on when it comes to dispensing in pharmacies, making sure that that does get structured appropriately given the nuances, and certainly employers want that service, in particular related to the ROI aspect of it. But yeah, that definitely something that needs to be looked at with how it needs to be structured in order to be provided to the employer.
Great, thank you. Cameron Kleffelder, any comments or questions?
No, I'm good, thanks.
Glenn Benjamin, any comments or questions?
Thanks, Larry. I apologize. I had to step away, so I'm not sure if you addressed this already, but performance guarantees, typically they're in these contracts. Is there sort of a standard that's out there?
I think you said you were asking if there were any standards for performance guarantees. Is that correct?
Contracting standards, for performance guarantees, are there sort of benchmarks that are out there that people typically use? I'm just very curious what.
I don't know, Stephanie, you want to comment? Any specific standards for performance guarantees or benchmark?
Yeah, I personally don't have any. I think Larry, actually, some of the resources we have had, you've had some of the benchmarking studies done in performance would probably be a good starting point, but no, I don't have any on that. And frankly, that for me, at least, that gets into more of the operations and the consultants and brokers that are handling that part of it. So I may not be the best person.
Yeah, and NAWHC has a guidebook for measuring the performance of worksite health centers, which has a variety of metrics and challenges and scenarios for both new and mature centers that might give some guidance. But clearly, every employer is different, and they'll have their own priorities of what those standards should be. But typically, broad areas would be cost, utilization, satisfaction. I don't know, Mike, Glenn, Matt, others.
Yeah, I'd comment that one thing to put into a contract that we always think about is when the setup or the initiation or development, having strict timelines and bonuses or penalties to be able to predict when the place is going to be open, when it's going to be seeing patients, at what stage it's going to be. That's the greatest dissatisfier that we see among employers, vendors making promises that aren't fulfilled. And then Larry, your document on the NAWHC website regarding performance of program performance would be the book I'd grab. And then I'd choose 5 or 6 that are really apparent and important. Always participation and satisfaction. The success of the clinic's sensitivity is to how many of your beneficiaries actually enroll and use the services.
Great, thank you very much. John Simonis, any comments or questions?
No additional questions. Just remember that clinical performance guarantees are going to be important.
Yeah, thank you very much. Melissa Wood, comments or questions?
No comments, thank you.
Susan Cogans, any comments or questions?
No, thank you.
And Mary Vale, any comments or questions? Mary? Okay. At this juncture, we are going to take a 5-minute break, allow everyone to get up and stretch a little bit. Again, pet the dog, get the coffee, relax. And so we will come back together in 5 minutes. So we'll see you in a little bit then. Thank you very much.
Thanks, Larry.
So we're now going to go to the second portion of our program. This is a free-fall interaction between all of our speakers who've been kind enough to join us today and on our audience. We're going to be talking about the issues, challenges, opportunities for hospitals and creating centers for their own employees as well as for area employers. And so Stephanie, Mike, Matt, and Steve and I will engage in discussion, and I'd encourage you to jump in as an attendee, take yourself off mute and include a question or an observation or an experience if you'd like. But again, after this session is formally over, we will still go around the table. But feel free to either speak up, or you could put something in the chat or the Q&A, and I'll take those questions as we go forward. So the first question I have for the panel is why do you believe that so few hospitals have been interested in success or successful in this marketplace? Matt, what's your thoughts about that?
I just got a little pop-up that says my internet may be intermittent, so give me a visual cue if that is the case.
Okay, you're fine so far.
Good. I think, and I can speak for our health system. We're an academic health system, and by definition, we're regional. So we're have a geography that is about 5 counties, but 4 of which are in the greater metro Milwaukee area. And we are looking to operate workplace clinics that are consistent with our geographic scope. So I think one of the limiting factors for a health system is going to be their geography and how broad their scope is.
Steve, your
as a
thoughts?
point of
Go
comparison,
ahead,
the 2
Matt.
other large, yeah, I was going to say the other 2 large health systems in my market are multi-state health systems.
Steve, your thoughts on this?
Well, obviously the last 2 years or so, health systems have had to really put a lot of focus on simple operations as we went through the pandemic. And so there's really been no room for them to have sort of external thoughts. But prior to that, I think people need to understand health systems have spent a great deal of time building their primary care networks. And on the surface, this could be seen as a disruptor to that primary care network that has so carefully been established. And so until they view it as an extension of their primary care network, it feels a little herky-jerky inside of a health system.
Okay, Stephanie, your thought?
Yeah, I really echo everything everyone said. I mean, I think the past 2 years, frankly, they haven't had time to think about this. They've just been trying to keep up with the changing landscape of COVID. I think in addition to really seeing this as an integrated part of primary care, it's really having full-time people dedicated to this. I mean, you heard Matt talk about with Frederick how they have, workforce that work just for employee health services. And I think I've seen some hospitals try to piecemeal it where they have a primary care physician who works 1 day a week at the employee health center or out in the community at the employer clinic. And then they have a, private practice on top of that. The administrative staff, even kind of the operations behind the scene, are trying to do all the other things at the hospital, where it seems like the really successful programs have a dedicated separate part that is for employer health services.
Great. Michael, your thoughts?
Yeah, I think the hospitals that we've worked with are entering the game late. They are reacting to something in the marketplace. They're not being proactive. They're doing something because, I don't know, QuadMed is in town or Care ATC, and they've never seen somebody from Kansas City come out to, I don't know, Chicago to provide services. So it's a shock to their system. They have an inability to really deal with employers. They have liaisons for channeling their market responses to consumers, direct to consumers, and then to managed care plans, and they interrelate with EPAs, but they're never involved in the employer forums or dealing with an outside sales staff to employers. They don't know what employers want. They don't know why they want it. And they don't have any, I guess what I'd say, communication or diplomatic status with employers. I think also hospitals are suspect as the cost drivers, and employers take a look at them as part of the problem, not part of the solution. And hospitals have to reorient employers to thinking of them as a potential partner for solving the issue of cost containment and not driving it. Staff is the other issue. Their doctors don't understand it. They're not dedicated to it, and they don't have a primary staff involved.
Yeah, and I would agree. I mean, I've worked with self-insured employers for close to 40 years, and hospitals have always used employers just for workers' comp issues. Otherwise, the health plans have been their top priority, Medicare and Medicaid. And they don't understand that employers as purchasers pay the health plans who pay the providers. And so there's a real need to understand what the employer is all about and what their motivation and needs are. And of course, many all hospitals are large employers, many times the largest employer in the community. And so there's a lot of things that they can do relating to this. Steve, let me ask you, so what do you think are the 1 or 2 key advantages a hospital would have in a marketplace for an on-site service?
Well, I think it's been said before, but they have cachet with a name, right? And if they've done it well, that name also stands for quality. It stands for somebody that's invested in the community. So I think they can rely on that for one thing. They oftentimes have relationships in the community. They have board members, you know, who are usually business people in the community that are sitting on their boards, or hospital executives typically sit on boards of other companies in that particular ecosystem. And then I think the big thing they have is scope. So they can leverage the expertise they have in a whole wide variety of areas. So they can be centers of excellence for different things. They can have high physician quality. They can have a wrapped product where they bring in physical therapy, where they bring in imaging, where they bring in lab, where they bring in mental health. You know, they have the ability to do that because they have those services in their umbrella, and they should do that on behalf of their employer clients.
Thank you. Stephanie, your thoughts? Key advantages for hospitals?
Again, echoing what Steve said, I've seen some employers say that they don't want to go with hospitals because they want independent referrals, but I've also seen hospitals, just like Steve said, they may be a center for excellence for cancer care, or have a pediatric hospital attached to them. And so they may have resources in the community too, that you may not find. I've also seen sometimes with hospital staffing, and again, this is outside perspective, but can be a little easier just because they have a larger network of physicians and nurse practitioners that they can pull from if there's someone that, quits or something. So I definitely think there's pros and cons out there.
Thank you. Mike, key advantages for a hospital? Take yourself off mute.
I'm trying to mute myself. I agree with all of the advantages that people have talked about. They do have a good sense of the community. They've already got a market plan for reaching consumers. They know their commercial customers. They can reach out and tell a commercial customer what they've spent at the hospital last year. And if they start with that and say, we can save you 10 or 15 or 20% on this if we can participate with you on a direct basis, that immediately starts a conversation when you're talking to an employer about something they don't know, but you have to be talking to the employer. I also think that hospitals have the great advantage of being able to bring capital to bear. And I think we saw this with the Volkswagen example, where a number of people were competing, and then the local hospital just simply went out there and built a huge clinic right at the entrance to the plant. The vendors are not really involved in capital deployment, and the hospitals can be and probably should be. So I think there's a network that hospitals have, perhaps in primary care, urgent care clinics. They can say we've got this network around town. They may be able to cover geographically the local area better than a vendor that might just locate in an industrial park. So there are lots of different advantages. The hospitals have the weakness that they don't package this stuff up and put it into the hands of a capable manager and say, go out and sell this. The concept that they've got lots of services, remember their services are all in interconnected but intercompetitive silos. So if I'm managing the emergency department, I don't necessarily like the guy in physical therapy who's taking resources away from me in a competitive budget cycle that's tougher and meaner every year. So hospitals internally don't work together the way we think they do. My experience as a hospital administrator and hospital consultant for several years.
Thank you. Matt, your thoughts about advantages a hospital would have?
Yeah, my colleagues here have mentioned, I think, all of the main ones. I'll offer some commentary from a couple of different perspectives. So Steve talked a little bit about the brand and the cachet. We really leverage Frederick Medical College of Wisconsin. We know from the Qualtrics data that in our markets, we are the #1 patient choice. So we've measured in the community and the market knows that our brand means value. So we take a great deal of pride in that, but it also connects directly to the staffing piece. And one of the advantages that we have is access to resources and to leverage that brand from a staffing standpoint. In my previous life, one of the greatest challenges was opening a workplace clinic someplace in the middle of nowhere where my brand didn't have any meaning in that market and from a staffing and recruiting standpoint. I would also say, I know Stephanie talked on specialists. Having access to specialists is certainly something that's also very important. I would also suggest that, independence when it comes to referrals is really, really important. And I would contend that you can't have a meaningful employer relationship if you're not respectful of direct contracts or plan designs that employer has. I happen to operate more than one workplace clinic on-site at an employer where they have a narrow network that I'm not part of. So you need to be understanding and respectful that the employer is doing certain things to either drive specific cost or quality outcomes.
Thank you. Michael started to mention barriers. What barriers exist for a hospital entry into this kind of field?
There's a long list. The first thing I would suggest is that you have a completely different payer model. So most health systems are used to managed care, they're used to RVUs, they're used to CPT coding, all of those things driving revenue. And to operate direct contracts or workplace clinics oftentimes means throwing all that knowledge out the window. Another barrier, I think, for a lot of health systems is what I would define as service line silos, where they're not necessarily accustomed to working across all of those unique functional disciplines. Most leaders in healthcare systems have spent their entire career in healthcare systems. You'll find folks that are doctors, physicians of all types, pharmacists, nurses, physical therapists, masters in healthcare administration, and they've spent their entire career there. So what all that sometimes means is that health systems don't know what they don't know. And if you've not worked in other environments outside of health system, you might not be able to bring some of those things to bear. And I think the last thing, and I know some of my colleagues will speak to this, is there's a meaningful and necessary partnership that needs to exist with other vendors in the ecosystem for the employer, primarily TPAs, carriers, and PBMs. And health system needs to look at those organizations as partners, not necessarily enemies or other competing firms in that space.
Thank you. Steve, thoughts about the barriers hospitals face?
I agree with everything Matt said. I think from my perspective, it'll be sort of viewpoint and control. So a health system has to learn to adopt a different viewpoint, and that would be of the employer, and take on much of a retail mindset in terms of what are we allowing the patient to have access to relative to scheduling? What are we allowing people to do kind of on their own, instead of a health system which usually says, your appointment is at this time, be there, do this, and you're going to have a great experience. So you've got to really change that whole mindset, which takes a little bit of time. And then control, you've got to get, IT departments comfortable that their EMR may be deployed in a location that they don't have complete and total control over. So it's not an owned physical space. It's maybe a place in a plant or in a particular employer's place. You've got to get HR comfortable with different sort of mindsets on hiring. You've got to get marketing more comfortable with marketing through the lens of the employer, not the health system. So you've got to be willing to give up some of that control in exchange for a different view of the world.
Thank you. Stephanie, your thoughts on hospital advantages or barriers, I should say?
Yeah, well, I won't repeat anything that's said, but I think one thing is just the national scale. So when we're working with both employers and on-site clinic vendors who are the traditional managers, not the hospitals, you know, they may have a client who has a headquarters in Washington and Massachusetts, and then has a few other sites throughout the country. And so they may be able to deploy those because, like you said, Larry, they kind of have a turnkey for those more. So, you know, I question whether the hospitals, you know, how well can they manage kind of a national client if they really want to serve all their employees and rolling out telehealth on a national model too. So that's what I've seen where most of the hospitals I've worked with or just seen doing this are working with either local employers or regional employers.
Thank you. Mike, anything else you'd want to say about the barriers to hospitals?
Yeah, none of the barriers are things that cannot be overcome. We went one time when a hospital presented and they were competing with one of the big vendors, and they were their own 990s were presented as a counter to their proposal. And in the 990s, of course, they had the compensation for their top level people, and then they also had their financial performance. And so it turned off the local school district where the administrator there was earning $160,000 a year compared to the 1.6 million that the hospital administrator was earning. So that public information and the fact that they're a nonprofit is a disadvantage. Also, they don't know how to do RFPs. So when a time-related response is necessary, they understand they've got a year to do something, or they put in the request for JCAH approval, and they've got 6 months to get ready. The RFP will come out and they've got to respond by the end of the month. They don't have the teamwork internally to be able to do that. The first thing we get from a hospital when we run an RFP is a request for an extension. Then they don't answer the questions that are in the RFP, so they can't even read what the employers or Mercer or Aon or whoever is proctoring the RFP has put together. Last point is the fact that they often have these internal silos, and when they do develop something, it is not a unified proposal. I won't go over what everybody else said, but I do want to reiterate the fact that they'll have to they won't have a medical director for their program. They won't have an administrative responsible party that can drive the program. There's no one phone number. The emergency department doesn't understand that this is a product line for the hospital. So there are many different issues. Lastly is the star rating. Yes, they've got a reference for that they perceive gives them a high level of visibility, but their urgent care center or ER may have a 2-star rating. Again, something that goes against them. They've got a track record in their own community. So Mayo Clinic's got a different reference and status, and Johns Hopkins has a different reference and status than some hospital in a local community that's been taking consumers for granted for the last decade. So I think there are barriers. They can all be overcome. They have to be understood and worked through.
Okay, let me shift the panel's perspective now to going beyond the hospital walls to within the hospital walls, and ask you all to comment on the benefits, opportunities, and challenges for a hospital offering clinic for its own associates, its own employees. Steve, could you comment on that, please?
I think there's a ton of benefits in doing that internally. One, a healthier workforce is going to provide a better product and better mission accomplishment for your organization. And move people out of your own primary care offices and into sort of a fixed place, which opens your traditional primary care doctors up to serve more of the outside community, which is a benefit. As we know, access is a huge issue. And then you get a lot of really robust data on some of the challenges that your employees are facing, and that helps you then create wellness programming and different things around helping your own employee base with the struggles that they face or their family members face, which again impacts your ability to deliver a product.
And what barriers do you see for a hospital in trying to do this internally?
Particularly when you start doing primary care internal, there's a lot of politics involved because your primary care group typically sees that as sort of stealing their patients. Particularly if you're sitting inside a PPO plan or whatever, where you can offer truly a free service. And so what typically results is you have no copay responsibility if they go to an employer-sponsored health center, and they do have to pay a copay if they go out to your primary care physicians. And so they view that as kind of inherently unfair and potentially impacting their compensation. So there are some political issues you've got to work through.
Yeah. Matt, your thoughts on the advantages and challenges for hospitals offering their own clinics?
Yeah, so Frederick Medical College have operated workplace clinics long before I was here. So the first one I think I mentioned earlier opened in 2006. And one of the drivers at that point in time is it was really difficult to get into primary care. Fast forward 17 years, it's still, at least in our health system, very difficult to get into primary care. So we established that initial workplace clinic for, kind of all the classic traditional reasons that an employer would, which is quicker access. So same or next day appointments, limit lost time, have a healthier workforce, right? So that whole value curve of ongoing wellness. We wanted to make sure it was free. And so I mentioned earlier that, one of the implications for that is that it has meant that we've had a limited scope. We also, at the time back in 2006 and for subsequent years, we didn't own the providers. So there was this political position or thought that the workplace clinics were going to be stealing patients and stealing care. Well, it turned out to actually be a non-issue, and became a non-issue, one, because capacity was already an issue. But the other thing was we really want to promote within primary care to allow everybody to practice to the top of their license. So ultimately, what we found out is that providers in the traditional primary care setting came to embrace the workplace clinics because it allowed the primary care docs to focus on kind of the higher order type things and refer a lot of the acute care, which again, due to the design structure that we have to make sure it's under ACA and it's either preventative or de minimis, to be able to get that care in the right setting.
Thank you. Stephanie, your thoughts on advantages and challenges for hospitals for their own clinics? You're on mute.
Thanks, Larry. From a legal and regulatory side, I think one of the biggest things we talked about was just the regulatory issues with the record keeping. For example, if an employee, is referred to EAP due to a workplace issue that is interfering with their job performance, and the EAP is part of the Worksite Health Center, how's confidentiality handled, how's return to work handled. So I really think the records are one of the biggest things I've seen pose a challenge, and just really needing to work through on the front end and have really good training then for all the staff, both in HR and on the management and clinic side.
Thank you. And Michael, your thoughts on challenges and barriers?
Well, the opportunities are you can establish a learning curve using your own employee base. You've got access to all sorts of information. You can establish protocols and policies. So that is obviously a benefit along with all the other health related benefits. The downside is the employees in a healthcare system are incredibly hard to manage. I won't go through the politics, but if you take a look at any of the indices for managed care plans, when you're talking about managing the health of nurses in a hospital setting or doctors or technicians, et cetera, they have a higher healthcare cost because they know all of the providers and they make their own selections, et cetera. And we had a employee population where we had some ungodly amount of C-sections, for example, very, very high, double what the national norm would be, and then lowest possible VBAC, veg birth after C-section. And when we dove into it, it was because the nurses and doctors all knew each other, and it was the birth by convenience, not birth by any sort of standard that would be acceptable on a medical scale for. And the same was true with orthopedics, different types of surgery. So it's a hard population to manage. You may not get the statistics that you want with your own population.
Yeah. I would just chime in on one thing Mike said, that I think from an employer perspective, if a hospital is coming to me and they want to manage a center for me and they don't have a center for their own employees, to me that reduces their credibility. And if they have a center and they've got some experience, I think it enhances that. So I think it all ties back. So let me start off, Mike. How does a hospital or health system get into the marketplace when there's already established third-party vendors there?
Well, you can partner with the third-party vendors. That's definitely a situation that's an opportunity. You can take a look at your large primary care medical groups and see which groups are covering which employers, because that's a natural entree. You can go to your board members who are employers and launch some sort of program that is complementary to a board member that's already committed to the hospital and committed to their business. I would look for vendors that are failing, and I would trail off. Right now, the vendor community, I don't want to say failing, but there are openers where, say, some large corporations require that things be rebid every 3 or 4 years. So I'd find out where those cycles are when openers occur. I would also go or have my staff people or marketing people attend different business functions so that they can find out where the community leaders are that are making decisions on things like employer managed healthcare and employer changes in healthcare. And then I'd try to launch something with a local TPA or maybe a managed care program, some sort of special programming for employers. We've also seen hospitals go into a consortium or coalition so that they can battle against the vendors' incursion into what they think is their marketplace. So there are all sorts of forms that they can use and initiatives they can take, but they have to sit up one day and say, this is a market that belongs to us, and we want to make a commitment to it, and we're going to grow and go into this marketplace.
Thank you. Matt, how does a hospital break into this area?
I think the most important piece is to define and understand the strategy for why you want to be in that space. We're not unique. We're a nonprofit. Mike spoke earlier about some of the maybe inherent conflicts or challenges resulting from operating as a nonprofit. But I share that because we have a very specific strategy. And in my health system, the strategy is not to be a funnel into other services. Quite frankly, I'm in a unique position where our hospitals, prior to the pandemic and since, our hospitals are always full, and it has to do with the fact that we're an academic health system, and we have very much sought after experts. Our strategy is to remain relevant. We recognize that as a health system, 60% of our net revenues are from commercial payers, i.e. self-insured employers. And those self-insured employers have a lot of options. We have two very large multi-state health systems in my market, both of which offer narrow networks. And so our strategy is about having meaningful relationships with employers so that we're relevant. I would also tell you or share with you that we have strategies around patient satisfaction and patient choice. In each of those areas, we want to be top decile. We are top decile in our market for patient choice and patient sat, and a lot of that is driven by and supported by the employer relationships that we have. So I gave some examples of strategy, but I think it's really important that you define and have very specific reasons as well as measurements for success for that strategy.
Thank you. Steve, your thoughts on how a hospital can be successful in the new market?
Yeah, I agree with everything that's been said. And I think that relationship piece is key, relationship with your business community and trying to help people understand that part of your strategy, which deals with sort of community health, community benefit, and leveraging that. And I think you need your C-suite to be out and talking through the lens of the employer, because you, that health system or hospital, whatever it is, you are an employer. And so talking through some of those challenges that you face, some of the key strategies you use to try to increase health, to try to control costs, those type of things, so that that relationship gets developed as solving a problem versus you just trying to gather evidence.
And Stephanie, your thoughts on that?
Yeah, I'm really going to defer to Steve and Matt and Mike on this, since that is not part of what I do. I would say the one comment on the nonprofit side, I agree there can be some issues there if we have nonprofit hospitals on, but I've also seen it really work to their advantage from a regulatory standpoint. There's a few states where dispensing laws and other things actually are different for nonprofits, right? And so it may be easier to do some of those things and achieve those. But as far as how to break in and market, I defer to this group on that.
All right. Well, Stephanie, let me ask you, how does a hospital prepare for an employer RFP or consultant RFP for a clinic?
Oh, that's a really good one. So yeah, I think on the RFP side, if they're going out to the community, I really like what Mike and you said, Larry, that, I really hope that they've had their own clinic they're running for their own employers first. And I would recommend, if they've never done one of those RFPs, to sit down before they even want to start going out to market with this and start going through all the business reasons they should do it, all the things that you would typically have on an RFP. And then on an RFP, where I get involved is, when they'll ask, well, what's the staffing model going to be? What's the dispensing model? The employer wants to staff with like a PA and do on-site dispensing, but in that state, dispensing is limited for PAs. And often what has happened, at least when I'm brought in, is the whole team wasn't brought in from the beginning. And had the whole team been brought in from the beginning on the RFP and been able to weigh in on their different areas of expertise, then we would have avoided at the last minute scrambling because, oh, wait, business thought they wanted to do this. Legal says they can't do this. Finance says it needs to be changed this way. So I would say definitely taking that team approach from the very beginning is helpful on the RFP side.
Great, thank you. Mike, how does a hospital prepare when a RFP shows up on their doorstep?
Well, the first thing that you've got to do is hope that you're working against the type of background that Matt was talking about. They know why they want to get involved and what they're going to do. The second thing is to parse the RFP and break it down into questions and answer the questions absolutely directly. Don't talk about don't answer the way you want to answer the way that you would feel that the employee would like to hear the answer. That's our biggest question on proctoring RFPs is, did they answer the question? Secondly, don't bend timelines. Don't try to negotiate through the RFP. Either answer it or don't. And address it or don't, or say that you can't, or that you'll address it later. These RFPs are so painful to read the responses sometimes. And then I would say have your presentation ready, because if you're lucky enough to go before a panel, you want to be ready, not surprised, and not putting something together at the last minute. And the thing that we tell hospitals always, in order to distinguish yourself from others, make a claim. And let's see, this was done in the Milwaukee area. We did it in Southwest Michigan. We've done it in other areas. Just stand right up there and say, we will guarantee based on our experience that you will save X number of percents on your healthcare spend, because we are the hospital and we can balance things against some of our internal inpatient costs where others cannot. And then the last trick we tell hospitals is bring the medical director along and say, we have a program in place. We're not guaranteeing that we'll set something up. Dr. Jones, she will be the medical director. We'd like to have her say, not the medical staff president, for God's sake, not the medical staff president, the medical director that's going to be in charge. If you can do that, you've got a shot at taking something away from Premise or Care Here or somebody else. You've got a shot at entering into the marketplace.
Thank you. Matt, your thoughts about the reacting to an RFP?
Yeah, I mean, everything the panel shared is spot on. I would say for health systems, it's really important to know your metrics, and it's important to know your metrics around things that you don't traditionally track. So one of the things that we track now, and we didn't always track it, is referrals. And we are very proud of the fact that in our external employer-sponsored workplace clinics, we're allowing our providers to practice to the top of their license, which means that just over 95% of all care is able to be delivered in the workplace clinic, or just less than 5% is referred out. And when we refer out, our top referrals are primary care, dermatology, physical therapy, orthopedics, and podiatry. So it's really important that you are able to source and track and report that, because that's going to be really important information to put into the RFP, so that you don't get unnecessarily or inappropriately boxed into a narrative that might not be correct for your specific situation. The last thing I would share, and I think one of the panelists mentioned it earlier, one of the advantages that health systems has is this great access to specialists and resources. But as it relates to the RFP, you need to make sure that there's a common voice, right? So I can go out to the best of the best medical professionals across a number of different disciplines, but I need to make sure that I craft that message so that it reads from the employer or consultant point of view with a common voice.
Thank you. Steve, your thoughts about reacting to our RFP?
Yeah, to the points that have been said, I would say when you bring that group together, bringing somebody from marketing is incredibly important, and not necessarily marketing like your graphic designer marketing, but marketing like your copywriter person, because you want to make sure your answers are complete, as Mike said, but concise, and don't bury the heart of your answer in the middle of this really long-winded paragraph answer. And copywriters are usually pretty good about, making sure that happens, and they'll write with the one voice that Matt just talked about. The other thing, if you can accomplish it, it is very helpful. If you can practice one, if you can find an RFP that's been in your community, if you know someone who's used one in the past, getting started that way can be incredibly helpful for when the real one arrives.
Great. Thank you. The last question I'll pose to the panel before we turn it over to the participants is, okay, you've got the RFP, you've been successful, you've been chosen, you went through the beauty contest and they've selected you. The contracts for 2 to 3 years. What do hospitals have to do in transparency to provide reports that will generate them to get a renewed contract? What do hospitals need to report? Can you talk about that? Steve, we'll start with you.
Well, I think that the first thing is you've got to, and depending on how the hospitals are structured, it's maybe one department or maybe two, but not only do you have to get your IT team involved to make sure you can actually pull data quickly and appropriately, but you need an analytics team involved, because the absolute last thing you want to do is provide a 50-page report to an employer that nobody has any idea what it says. So you've got to make sure as that data flows that it's actually actionable information that can bend the healthcare curve for those employers and furthers that relationship towards the common goals that you're shooting for. The other thing that we strongly encourage people to do as they sort of win those contracts, put together a report card that is sort of combined thinking between you and the client of what defines success, so that as you meet with them and you provide that information, those analytics, there is a common goal that you're shooting for. Because otherwise what happens is sometimes you have hospitals who focus on the things they like to focus on and call those success. And you got a whole different set of metrics that the client's focused on it. And then you get to 6 months, a year, and you're not speaking the same language.
Thank you. Mike, your thoughts on what needs to be reported to employer?
I would immediately go back to the RFP and see what standards were put in the RFP. I'd go to the 2-page type thing. 1 page is a couple of graphs or tracking mechanisms that are consistent month over month. And then the 2nd page is sort of a what's happening. If there's something on a graph that is remarkable, it's footnoted to the 2nd page so that you've got some explanatory stuff, not just the graph. I would hit a couple of big items that you can control. One would be emergency department utilization. If you can off that to the onsite, to the telehealth, or to the urgent care stuff that the hospital has, that's usually a pretty remarkable thing. Also, if you can do something about patient bed days, either cost or diminishing patient bed days, your hospital or others, I think that's important. So it's a 2-page report, consistent month over month, based on the RFP criteria as much as possible, and in the hands of the decision makers at the organization. I know that patient compliance is important, but patient satisfaction is even more important. Satisfaction is not quality. It's accessibility and the geniality and reception of the staff. A report that's printed is useful within the hospital to show each other how great we're doing, but you have to have at least a quarterly meeting between the medical director, the HR, and the top level people at the industry or the employer's site to read them the reports you've been sending and find out if that is, to create the feedback loop. Sending out these reports means nothing. And we've gone in several different times when the reports are great, but there was no communication. Great reports, no communication. So if you don't have a communication process, you're going to lose out.
Thank you. Stephanie, your thoughts on reporting?
Yeah, I would say agree with everything everyone said. And so talking about what type of reporting, just from a contractual standpoint where I get involved, is I would make the reporting very clear in the statement of work as to what reporting you will be giving to the employer. I have seen times where that's not really set forth and the employer has wildly different expectations than what the Worksite Health Center has as to the type of reporting they'll be receiving and the frequency of the reporting. And then I would also consider, if that employer is going to start asking for really customized and special reports that are using, metrics and things that you haven't ever tracked before, and it's not in that standard set, is that something the hospital's doing for free? Are they charging extra for that? So I just think you need to be really clear up front on that reporting. And if you have performance guarantees in your contract, how that ties in. The other thing I have seen come up as an issue is I have seen employers want to audit utilization metrics and reporting, and look at the background data, how you got that. And so, do you have audit rights in your contract, and what do those look like on that side too?
Thank you. And finally, Matt, your thoughts about reporting?
Yeah, I'd say with the assumption that it's either an opportunity that came through an RFP or a workplace clinic takeover, I think reporting is probably going to be established and defined by the employer what their expectations are. The other thing I would say is, due to my proximity to Verona, Wisconsin, Epic was not built and designed for workplace clinic vendors, right? It was built to be an electronic medical record for healthcare professionals, and out of the box, it is expertly situated to do individual quality and outcomes reporting. When Frederick Medical College of Wisconsin implemented Epic, they didn't implement it for the purposes of our employer services group. So with all of that, there's a very important relationship that needs to happen with your IT department and your project management department as it relates to taking the functionality that is already designed from an individual reporting standpoint and being able to do broader reporting from a population health standpoint. So that's ultimately what the employers want to be able to see is a before and after comparison or a comparison between clinic users and non-clinic users. And that speaks to not individual reporting, but reporting on a population.
Great.
Yeah, Larry, another thing on the reporting, if you don't mind me jumping in here, that health system should be thinking about is who owns that reporting, right? So if you're likely your reporting is going to have de-identified aggregated data that needs to comply with HIPAA's de-identification standard. And so if you give that to the employer, can the health system use those metrics, the de-identified data, for marketing purposes or for other RFPs? And, so I would clarify that in the contract. And then I have also seen, I don't know about health systems, but just clinic managers in general contract with companies that do analytics for them. So there's a number of companies that do that, even here in Indianapolis. And if that's the case, who owns that data? What can it be utilized for? And just that part of it needs to be really clear.
Great. Thank you, panel. The only other comment I would make, not necessarily on reporting, but in general, we had an experience recently where a hospital had developed an on-site clinic for an employer for 3 or 4 years, very successful. The employer was thrilled. And then the CEO changed at the hospital and decided this is not a line of business they wanted. And they gave the employer 3 months to get out. They told them they were leaving. So the point I want to make is make sure your senior management is on board before you begin offering this kind of service. And if you're planning on making a change, make sure you give your clients sufficient time to make any transition. At this time, I'm going to turn it over now to the participants. So as I call your name, please, any questions on any topic we've covered or anything we haven't for the panel, feel free to do so. This is your time. So Susan Coggins, Susan, we'll start out with you. Any comments, questions you have on any topic at all?
Oh, no, thank you.
Okay. Let me ask Alex Jordan, any comments or questions on anything?
Have one question. Great comment, great presentation. Thank you. My one question is, how do health systems overcome kind of the stigma that referrals or propping up these employer-centric centers are going to be feeder roles in the systems? How do you guys approach that messaging or recommend approaches to that? And are there analytics that can demonstrate kind of the opposite of that?
Matt had some good comments about that, I thought, and what Freudert is doing. They're tracking the referrals and reporting back, I believe.
Yeah, I would say that boils down to transparency. Most of the workplace clinic vendors that are participating on this meeting, I would contend that 80% of the data that's being communicated in the monthly or quarterly report, although it might look different, is going to be the same across vendors. And so you're going to be reporting on things such as total visits, what was the breakdown of provider visits versus nurse visits versus physical therapy visits. You're going to report new patients versus an established patient. So you're going to be tracking all those metrics, and part of which is going to be referrals. So we believe in transparency. It's consistent with our strategy. So in my market, in my health system, we're not looking to refer into our specialty groups because, quite frankly, the waiting time to get into our specialists is already too long. So we really want to maximize our ability to manage as much of the conditions as possible in the workplace clinic. And oh, by the way, that's consistent with what the employer is looking for.
We placed our protocol for referrals if we could get it into the RFP. And if there wasn't a question around that, then we definitely put it in our presentation. And we also were very transparent about referral data. So how many were inside the system and how many were to the outside. And we trained providers very carefully on making sure that they followed patient preference, not convenience for them in terms of how the referral is made, because it's always easier to refer inside than outside.
We had one situation or one issue in which we were dealing with a client, which was very similar to Freudert in that they were already best in class in many of their different categories, but you couldn't get in. So we went to the orthopedics, cardiology, some of the surgical lines. We couldn't get dermatology, of course, because nobody can. And in every case, we got guarantees from them that the people would be able to get in if they came through the employer clinic process, would be able to get in a timely fashion, because the test of quality is often, can I get an appointment with a top level specialist in a timely fashion? And so we sort of reversed it and said, your people who can't get in right now are going to be able to get into the top orthopedic line in the city at a price that's guaranteed. And if the orthopedic event occurs on Tuesday, they'll be seen by an orthopod in the primary, in the top level group within 24 hours. And that was a big win for the hospital system. So sort of reverse, but we already knew that we were the best. Let's put it that way.
Yeah, that's really a good point. When a referral is necessary, there's really kind of two things that come into play for our providers. And this isn't unique to Freudert. I think many of the clinic providers do this. We actually facilitate with, on behalf of the employer with their consultant, we facilitate no less than once a year to make sure that our providers and our medical assistants and all the people that work in the on-site clinic have a formal meeting with representatives of the health plan. And it's really important for us to, I mentioned earlier, be respectful of the health plan design and recognize that an employer might have preferred networks or tiers of providers. And so even though it may mean our workplace clinic providers not necessarily steering or directing towards our health system, it's really important that we respect that. At the end of the day, the patient has choice. And so as it relates to access to expert resources, if there is an eye injury and the person needs immediate care, we're better equipped if the provider in the workplace clinic can call the Eye Institute and on behalf of that patient, look to get them scheduled sooner than they would otherwise.
Thank you. Anything else, Alex?
Just one more question. I know health care systems usually don't have challenges with marketing or communicating direct to patients once they're in the system, but there are challenges when it relates to reaching out direct to employees who aren't or haven't established care yet. Any, I guess, thoughts on capabilities or recommendations how healthcare systems can be better at direct to employee marketing and or communications, not reliance solely on the employer doing it on their behalf if people haven't established care?
I'll jump in with one comment though. If you are a health system, you're a covered entity, and HIPAA's marketing rules also can be a little strict as far as reaching out direct to employees and patients, depending on, if there's any exceptions or authorizations. And so again, probably a whole nother webinar there, but it's something I think that we need to be thinking about if they're not currently patients of the clinic. But Matt, you can give a much more practical answer than me.
Yeah, I would say the Frederick Medical College of Wisconsin marketing and communication departments are experts at communicating to individual consumers, but they don't necessarily, they're not dialed into the voice of the customer the same way me and my team at Workforce Health are. What we've done, Alex, is we have a marketing person that sits within our service line, that sits within Workforce Health, that dotted line to our broader marketing team, but our marketing person in Workforce Health is dedicated to voice of the customer and taking all of the resources that are available from the health system and tweaking it so it's appropriate for patients that are either employees or for employers.
Steve, any thoughts?
You know, my experience is that in a couple of cases that we've worked, the employer partners with the hospital to launch a program to assure that there's going to be compliance and participation. One of our Dallas-based employers sent out and coordinated with a hospital something like 300 communications to each employee before the clinic opened. A lot of it was progressing on the clinic and opening up channels of communication that were atypical, using social media, table tents, cafeteria type things, outreach to the employers, work groups and workstations, that sort of stuff. So it was very, very unique, but they had tremendous participation in their first couple of months in their after their opening. And it was all through hard work and very, very, I guess what I'd call just pick and shovel communications.
Okay, thank you. Mary Vale, Mary, comments, questions? Go ahead, Mary, take yourself off. No. Okay. Bohan, any comments or questions?
A question in respect to just helping the hospitals understand the compensation and financial model when they're working with employers, which oftentimes isn't going to be the fee for service. So how would the hospital help, or how would you help the hospital understand what that would look like when they're going into some of those relationships?
Well, we can share with you the ways that vendors are doing it in typical communities of where they're not hospitals necessarily, and that will be the model you'll be competing against, and that is generally cost per employee per month, or cost per incident of care, or some sort of combination of startup costs plus ongoing costs. And it's a pretty simple metric, along with a bonus for timely completion or achievement of initial goals in the first quarter. It's not fee for service, it's not capitation, and it's not bundling. It's straight. It's contract performance.
Other comments from the panel on that? Okay. Glenn Beljan, any other comments, questions?
Yeah, thanks, Larry. And actually, to follow up to the question I just asked, I was thinking about in your presentation, you showed the contracting sort of shared risk arrangement or risk arrangements that are kind of still relatively low. I'm curious to know if that's a growing trend, that more employers are asking the vendors to go at risk part of all. And is there any sort of advantage for the hospital system to take on risk, since they seem to have more control, as the panelists have talked about, ER services and such? So is there any advantage to a hospital versus a third-party vendor?
Matt, do you want to comment on different risk models, risk sharing?
Yeah, I think firstly you have to have something at risk to have risk sharing, and that's consistent with what your strategy is. One of the specifics on our strategy is we don't operate Workforce Health as a revenue center. When I build a pro forma for a workplace clinic, I'm looking at a 5-year break even. So financially, I'm in a very different situation than any of the purpose-built clinic vendors. Also, I essentially don't have any risk or any management fee or any other revenues to put at risk because I'm operating in a financial model where we're looking to break even over the long term. I think that if you are operating as a revenue center, then certainly the hospital has an advantage to being able to put some of those management fees and a risk sharing opportunity with the employers.
Steve, your thoughts?
We had several risk arrangements, and I actually kind of liked them because it aligned incentives. So it helped people understand that the outcome was better health and lower overall healthcare costs. And so everybody was aligned then to do the things that they needed to do to make that happen, whether that was extra education, whether that was extra resources, whatever the case may be. And so it did create nice alignment between the health system and all the resources they could bring to bear and the employer and how much they were willing to engage, because you still need employer or client engagement. You need their team to provide that access. You need them to talk about it. It needs to be important. Employees of that client need to understand, why the employer is offering that health center, those type of things.
Mike, any comments?
We love the risk-based model. Hospitals understand risk. The employers understand total cost. And so they understand risk basically because they're fully at risk. They're, self-insured. So that's all risk to the employers. And so we'll take a look at the general healthcare spend year over year, what it's growing, how it's growing, and what's included. We'll put in dental, we'll put in imaging, we'll put in anything that relates to healthcare that they're paying for, chiropractic, anything, we don't care. All goes in one pot. And then when we talk to a hospital or when a hospital's developing something, we'll share with them, we'll say, how much of this are you getting? And if they're getting 30% or 40% or whatever the number is based on their inpatient or primary care, we'll say, gosh, how much are you willing to afford in cost savings if you get more? And that's beyond the on-site clinic. That's the overall strategic premise of the hospital for getting involved in the commercial business in a larger way. If they're at 60% commercial, can they go to 65% by working with a particular employer? We stay away from bundling. That doesn't work. It's all about risk and it's all about employee commitment to the on-site program and to the employer-managed healthcare partnership with the hospital. So we think that works to the hospital's advantage because an outside vendor can't do that. They don't have any understanding of the risk side that's associated with the hospital balance sheet and income expense statement. Hospital has the advantage here. Hospitals fail generally to understand that advantage or be able to put it into a contract form that's acceptable to an attorney, a compliance officer, and to the employer.
So Stephanie, are you seeing increasing trends in risk sharing? You're on mute.
Thanks, sir. Yeah, no, not really. I would kind of defer to everyone else on the risk. I don't get quite as involved in that other than once there's a decision made as to what that is, just making sure that the contract is very, very clear. So we're not arguing about that a couple of years later.
Exactly. Thank you. John Dawson, questions, comments?
Overall, this has been really interesting. I don't have any questions, but I do have a comment related to reporting. I think that a lot of employers would get really nervous if your reporting is going to be different based on what was asked for in the RFP. So it's really important to have your standard report that you can say, this is how we do it. And I think it would become cost prohibitive to have different reports for every client based on what they're asking for. Just a Wondering if there's any comment on that.
Any thoughts?
I would agree.
Yeah, totally agree. I mean, that's why we like to have kind of a standardized list of reports set forth in an SOW, so you're not having to do the custom ones every time.
Sure, I just think that if you've got 10 different employers in your system and you've got Mercer doing one, Aon doing the other, and then some local TPA doing the other RFP, that's part of the thing that you're going to have to negotiate up front because they may come at it with some different reporting standards. I urge everybody to, on this call, to join NAWHC only to get access to their library so that you can get Larry's report on ROI and on the standards. I guess they get it for free, don't they, Larry?
That's correct. That's correct.
Okay, there you go.
Thank you.
The thing that I think is important about reporting is you have to be reporting to support your operations, to support the success of your on-site health centers. And frankly, I do care a little bit about what Mercer and Aon and everybody else asks for, but what they should care about is, does my reporting make sense to the operation that we're selling? And I think that's a good perspective for a hospital system to have. Why are we doing this? And what are the reports that are going to help us do it even better? And then demonstrate that we did a great job.
Yeah, John, you're echoing, I think, something that Matt said earlier. If you don't know why you're getting into this business, don't get in. I've worked for 2 national organizations now, both of which will go unnamed, at the national level. And then when we tried to deploy it at the local level, total absolute flop 2 times. The only people that made money were the consultants and the lawyers. So I'm thankful for the business, but I wish that they had been successful. I'd still be working with them. And it all fell down on the point that you're talking about, reporting internal to the organization that you're working with.
Thanks very much.
Thank you.
Lastly, John Samades, comments or questions?
None for me. Thank you.
All right. And Mary Vale, last chance, Mary. Any comments or questions? Okay, well, with that, I want to thank everyone for participating in the program this year on the hospital getting involved in the worksite centers for their employees and others. Our next program in March is going to be very interesting. It's going to be on how to incentivize patients and providers to get better outcomes for care. So I hope you're able to join us there. Again, this will be recorded and available for on the website and of course sent out to those who participated. So Matt, Steve, and Mike and Stephanie, thank you so much for all the time and effort you made to prepare and plan for this event. And thank you all for attending. Everybody have a safe and enjoyable week. Bye-bye.
Thank you.
Thank you very much.
Have a great afternoon.
Thank you.